All right, can you guys hear me? Excellent. Welcome everybody to our first in-person Hive P2 Simon Searchlight Conference. I'm thrilled to be here. I wanted to thank the families for making the effort to come. I know it is not easy for many of us who have children that traveling is difficult and getting out of routine is difficult. But I think that all of us being here is making a tremendous impact for our community. So wanted to personally thank all of you guys. Also want to give a huge shout out to Simon Searchlight and everything that they've done for us for almost the past year trying to prepare for this conference. There's been a ton of behind the scenes work, so we're incredibly grateful for that. Before we get started, since we are such a small group and a lot of us are meeting for the first time, I just wanted everyone to take a minute to introduce themselves. And for those of you that don't know me, I'm Nerissa Ramsey. My son Curran is the little bubbly guy in the wheelchair that doesn't meet a stranger. You guys have probably pretty much all seen him. He's 8. He was diagnosed when he was 2 years old. And at that point, Dr. Sid's first paper presenting 3 Hive P2 cases was the only information that was available. That was 6 years ago, so we've come a long way. Okay, I've got a quick introduction. So these are our Hive P2 kiddos. Just wanted to talk a little bit about Simon Searchlight and what they've done for our community. Simon started helping us pretty much right off the bat in 2016. They've held virtual conferences for us every year since then. Started talking about doing an in-person conference several years ago. So I'm thrilled to be here today. What Simon's is doing for Hive P2 and other communities is so important. Because it's really making our condition attractive to researchers so that we can better understand Hive P2, so that we can better understand how to support our children. And so I think newly diagnosed families often get handed a couple papers and say, you know, there might be up to 20 cases worldwide. All of us in the Facebook group, that's actually not true. We've got about 112 cases that we know about and 94 in our private Facebook group. So if any of you guys in the room aren't in that, the Hive P2 Gene connection is a great place to stay connected with families. And just going through some of the things that seem really common amongst our kiddos, and the researchers are going to talk more about this. It's really great to see everyone in person, see some of the similarities and some of the unique features of each of our kids. But common issues seem to be communication, safety awareness, impulsivity and hyperactivity, poor balance and coordination, and sensory dysregulation. Hopefully you guys have found some really great resources on those from the talks yesterday. And things that we've identified that are important for researchers to look into are that our children often seem to have a really high threshold for pain, different than typical children. Seems like there's issues with growth. Sometimes kids are having a hard time growing. Sometimes they're gaining too much weight too quickly. Families are very interested in understanding medications and treatments to help improve some of the symptoms. And some of the developmental testing is hard as a parent because it doesn't seem like it's capturing our children's true abilities. And really interested in knowing what the progression into adulthood looks like, which is wonderful having kids like Nate here. And some of these older children, it's really amazing to connect with you guys. So with that, I am going to hand it over to Dr. Sid and Alisa Mo from Boston Children's Hospital, and they're going to talk through their most recent paper that just came out with more information on Hive P2.
Hi, everyone. Like Nerissa said, my name is Alisa. I'm one of the Child Neurology Fellows at Boston Children's Hospital. And today I'm going to be talking, along with Dr. Sid, about the neurodevelopmental profile of Hive P2 disorder. So, and this has been a huge collaboration between us and the Searchlight Foundation. And like a really big thank you to all of the wonderful families here who have participated with Searchlight and answered all of the questionnaires and answered all of the surveys that really formed the basis of what we're going to talk about in our study today. So here I've listed some of the core clinical features of Hive P2 disorder. These include distinct facial features, varying degrees of global developmental delay and intellectual disability, autism spectrum disorder, hypotonia, and I think in terms of meeting all of the Hive P2 children, I've been really struck by how, in general, how happy they are, how bubbly they are, but there can be some behavioral challenges as well. So these can include hyperactivity, aggression, and anxiety. So the challenges, though, in terms of defining all of the conditions that we have listed on the previous slide are that there's such a broad range of phenotypes. So, for example, if we take intellectual disability, individuals who have very mild intellectual disability can be able to live independently, whereas those with more moderate or severe forms of intellectual disability may need help with almost all of their activities of daily living. And so the main goal of our project has been to better define the neurodevelopmental profile of Hive P2 disorder. And so we use prospective data from 12 participants with Hive P2 disorder from the Searchlight group. And we use the standardized measurements of adaptive behavior, social communication, autism symptomology, and behavioral and emotional symptoms to try to better characterize what are the core clinical features of variants in Hive P2. So here I've listed the demographic information of the cohort. So again, there were 12 individuals. The youngest individual was 3 years and 3 months of age. And the oldest individual was about 12 years, 9 months of age. And almost all of the individuals had de novo variants in Hive P2. Most of them were nonsense variants, meaning that there was a premature end to the gene, to the protein. And all of them had a classification of being likely pathogenic or pathogenic for Hive P2. And so here I'm just showing you a picture about, let's just look at schematic about the Hive P2 gene. And in the large gray rectangles are the regions that code for the protein. So kind of listed towards the right-hand side of the screen. And you can see that all of the participants have variants pretty much throughout the entire protein coding gene. They're clustered in exons 5, 9, and 10, but they occur both in the beginning as well as in the end of the gene. Yeah, so there's different kinds of mutations or variants that can happen in the gene. So there's 3 kinds. There's nonsense, meaning that when a gene gets made into a protein, there is a premature stop, so that not all of the gene is transcribed. Frame shift is similar in that there's also a premature stop, but it's because of there's not necessarily a premature stop, but there is a shift so that there is like one nucleotide missing, or for example, one nucleotide added, so that it shifts the reading frame so that different proteins are added that shouldn't be there. Different amino acids are added. So the protein is formed in a different way than it should be. And then the last category is missense mutations, which means there's a single misspelling and there is leading to one change in one of the amino acids, so one of the building blocks of the protein. Sorry? Yeah. Yeah, there's a few. I think there's one in the study. One Missense, one friendship, or two friendships, and then two. Yeah, so pathogenic just means that it's disease caused. So there's different classifications based on what we know about different variants in the gene. And it's just a classification system for clinicians or for scientists to know whether a variant is likely to cause this disease or not. Because all of us have genetic variation, all of us have misspellings and variants in genes, but not every variant causes disease. Right.
Oh, yeah, can you just explain, like, go back a slide for me? And so it says likely pathogenic, that first one, like, what does
Yeah.
that mean?
Yeah, so that's a really good question. Typically, I think for clinical and for research purposes, we think about likely pathogenic and pathogenic as almost like one category of most likely to cause disease versus the other variants are like things like variants of uncertain significance or benign variants that are not as likely to cause disease. And there's different criteria that so ACMG is an organization that they use to categorize, like to differentiate between the pathogenic category and the likely pathogenic category. And it's really about like how much evidence there is to support the classification of the variant. And so this is something that changes over time. And so, and having more data about the likely pathogenic variants can sometimes change that classification into pathogenic, but it's a tool for us researchers to try to classify genes. Sorry for the somewhat technical explanation. So here I've listed some of the specific neurodevelopmental and behavioral issues that are faced by individuals with variants in Hive P2. So about 100% of individuals in our study, in our cohort of 12, had either global developmental delay or intellectual disability. Most individuals, so 90%, also had hypotonia or low muscle tone. And about 60% of individuals had language delay. And half of individuals had a formal diagnosis of autism spectrum disorder. There are also some individuals with movement disorders. So these things are like dystonia or other motor movement disorders. About a third of individuals had microcephaly, meaning that their brain size was or head size was smaller than typical. A third of individuals also had high muscle tone or cerebral palsy. And then a minority of individuals had seizures and epilepsy, ADHD, or anxiety. When we look at systemic features, we find that most kids with Hive P2 are generally very healthy. Some of the challenges that they face could be in vision. So about 50% of individuals had vision difficulties, most commonly strabismus and farsightedness. And so these things are problems that can be fixed by glasses. And so it's really important for individuals with Hive P2 to go see an eye doctor. About 50% of individuals had GI problems, most commonly constipation. And then there is a subset of individuals who also had failure to thrive, or difficulty growing, especially early in life. 20% of individuals had asthma, 20% of individuals had eczema, and then a few individuals had problems with their immune system, musculoskeletal conditions, and genital urinary conditions. So overall, the takeaway slide is systemically, most individuals with Hive P2 are relatively healthy. So next, we looked more closely at the neurodevelopment. And the first thing that we looked at was the Vineland Adaptive Behavior Scale. And this is a measurement of adaptive behavior. And so these are the types of behaviors that allow someone to function effectively at home, at school, and in the community. So things like getting dressed in the morning, brushing your teeth, going to school, listening to the teachers, communicating with teachers, etc. And the Vineland has a composite score, so like a total score, with a mean of 100 and a standard deviation of 15, and lower scores indicate greater impairment. And then the Vineland also has a subdomain score. So the subdomains are in motor skills, communication skills, daily living skills, and socialization. And when we look at the Hive P2 cohort, we see that on average, looking at the composite score, that they score 56.4. And this translates into an overall mild limitation of adaptive behavior. And you can see that there's also similar scores and similar degrees of impairment in each of the subdomains. So in motor, communication, daily living skills, and socialization. What's also important to appreciate from this slide is that there can be significant variability. And we see that especially in the activities of daily living. So in that category, I think there was one individual who had borderline level of functioning, 3 individuals with mild impairments, 3 individuals with moderate impairments, and 1 individual with severe impairments. Next, we looked at the social responsiveness scale, which is a measurement of impairments in social and social communication behaviors. And this can also be used as a screen predominantly in research studies for the risk of autism. And again, there is a total score, and then there's also a subdomain score for social awareness, cognition, communication, motivation, and mannerisms. And opposite of the Vineland here, here higher scores indicate greater levels of impairment. And so if we look at the SRS-2 scale for the Hive P2 individuals, we see that overall their scores are average to 76.4. And this suggests that there is, in the category, in the typical classification system of SRS-2, a severe level of impairment in social and communication skills. But again, there is such variability. And so there are some individuals who are in the borderline or normal range, and others that are more severely affected.
And abilities, right? And I'm just wondering if you guys have had a chance to look, is it mattering on the gene where the change is falling, or are we seeing patterns if someone is a missense or a nonsense or a frame shift in terms of how the families are answering some of these questions? I'm just curious if any of that's correlating to where we're seeing some of the scores fall here, pending what the change is and where it's located on the gene.
I think that is such an excellent question and such a future direction for us, because again, like you mentioned, the numbers are quite small. And so we did look, is there a relationship between these scores and what type of mutation there is, and like where it falls in the gene, what kind of mutation it is. And we didn't see a correlation. But again, I think there is probably a correlation somewhere. We just have to look harder to find it. And I think we need more people and more numbers to be able to get that kind of data that we need. One thing that I want to point out is that motivation is relatively spared. So so the majority of the kids who have Hive P2 are very motivated to do well and to participate in therapies. And then we looked at a measurement called the Child Behavior Checklist. We looked for the older age group, so this is for ages 6 to 18. And this measures the degree of behavioral and emotional symptoms. And there's different domains. There's the internalizing domain, which is divided into anxiety and depressive symptoms, withdrawal and depressive symptoms, somatic symptoms, and the externalizing domains, so things like aggressive behavior, rule-breaking behavior. And then there's also domains of social problems, thought problems, and attention problems. And overall, individuals with Hive P2 do have clinically significant scores in the total domain in overall behavioral and emotional dysregulation. Most of it comes in the external subdomain, so acting out, irritability, aggressive domains. And relatively speaking, the internal subdomains, so being anxious, being withdrawn, those are relatively spared. And again, if you look at the subdomains, the main issues tend to be in problems of in social problems, thought problems, attention problems, and aggressive behavior.
Thank you. Do you know how many kids in this cohort had at least phrase speech?
I don't know. I don't think it was in the recorded in the. I didn't see it listed in the questionnaire that we got. But we can look more into it.
It would change how I would interpret a lot of these scores. So I was just curious.
Yeah.
Because for example, a lot of the questions for internalizing behaviors require that the child be able to tell you that they're worried about things or they're sad about things. And so often in these types of syndromes, we see higher externalizing scores and lower internalizing, but it's more a manifestation of the fact that we can see externalizing behaviors. We can't see internalizing behaviors.
I definitely would agree with that. I don't, we don't have the numbers of individuals who use phrases to make the determination, but I think there's a lot of caveats to the interpretation of a lot of these measurements. Especially for individuals who can't express how they're feeling. Yeah, so that's a really important caveat. So lastly, we looked at the correlation between autism symptom severity and adaptive functioning. So it's a little bit of a confusing slide, and we don't have enough individuals in the study to do a true correlation analysis. But you can see that overall, there's a general trend towards individuals who have higher SRS-2 scores, so higher degrees of autism symptom severity, and lower levels of adaptive functioning. And this has been shown for other neurodevelopmental disorders as well. So in summary, our study showed that Hive P2 affected individuals have a significant range of neurodevelopmental phenotypes. Some of the most common challenges include intellectual disability, autism, and hypotonia. Less commonly, epilepsy, movement disorder, and ADHD. And we also show that there are impairments in adaptive behavior, social behavior, and emotional behavioral symptoms. And when we look really closely at the data, we also found that individuals who had a diagnosis of autism actually scored similarly to individuals who did not carry that diagnosis of autism in the measurements of the social behavior. And this suggests that there are, a couple of possibilities. The first possibility being that individuals who don't have the diagnosis of autism may potentially benefit from similar types of therapies as the ones who do carry the diagnosis. It's also very difficult to diagnose autism in neurodevelopmental disorder. So another possibility is that could be underdiagnosed. And I think overall, we've shown that because of these neurodevelopmental impairments, children who have Hive P2 can really benefit from the therapies that Sid is going to be talking about next, such as speech therapy, occupational therapy, and therapy. I'm going to turn it over to Sid.
Thank you so much, Alisa. So I wanted to switch gears a little bit and try to take this knowledge that we're describing and reporting about and translate it into something that may be practical for you guys in the audience. So I wanted to present an overview of different types of strategies for addressing some common neurodevelopmental themes and challenges that we see in Hive P2 disorder. So a couple of different recurring neurodevelopmental concerns or challenges, and some of which Nerissa alluded to earlier. So communication can be a huge challenge for this population. Behavior can be a huge challenge, and that includes hyperactivity, includes aggression, includes anxiety, includes self-injurious behaviors, includes so many different facets, repetitive behaviors. Sleep can be a challenge as well. I think sleep is very important for functioning in everyday life. If you imagine anyone who doesn't have a good night of sleep, they're going to be not so not so well functioning the next day. There are going to be challenges. So you can imagine a child with a neurodevelopmental disorder who's not sleeping well, that their functioning the next day can certainly be impaired due to the lack of good night's sleep. We'll talk about seizures, and that's not because it's a hugely common occurrence within Hive P2 disorder, but it's a question that comes up a lot. I think a lot of families express concerns about seizures and epilepsy, so I wanted to address some of those concerns. Motor challenges, including the hypotonia or low muscle tone, coordination difficulties, motor impairment. These are some challenges that we see over and over again in some of our families, so I wanted to talk about that as well. The last thing I wanted to address is future outlook, capacity for independent living, and what drives that, what's the basis for understanding that decision or those kind of decisions. So the first of these themes I wanted to touch base upon is communication. And I know there's been talks about this in more detail, so I'll present a very high-level overview. Communication basically is our ability to interface with the world. And I like to think of communication as having two different components. There can be an expressive component and a receptive component. Receptive component is our ability to understand what's being told to us, whereas expressive communication is our ability to communicate those thoughts and ideas to the rest of the world. And of course, communication is such a huge, huge, huge domain for Hive P2. There are different ways and strategies for addressing communication disorders and Hive P2 disorder. The three kind of big categories I like to think about are, so number one, individual speech language therapies. Number two, play social groups. And number three, augmentative and alternative communication. So individual speech therapy is fairly self-explanatory. It's where a child or individual works with a speech and language pathologist, working on different facets of communication that may be impaired. When I say play social groups, I mean modeling social communication behaviors with by examining or by playing with others, with other individuals who may be typically developing and learning or modeling some of those types of social communication or healthy social communication behaviors. I'll talk a little bit more about augmentative and alternative communication. This idea, AAC, basically refers to the use of special devices, equipment, etc., that allow an individual to communicate even if they don't have, or especially if they don't have spoken language. So these devices can be high tech, so they can be iPads with communication programs, they can be eye gaze devices and so forth, or they can even be low tech, such as the use of picture boards, which is illustrated below. I really like to talk about AAC, especially for children who are nonverbal or minimally verbal, because I think it's a really great intervention. Some families wonder, does AAC impact spoken language development? And the data actually shows the opposite, that AAC can actually improve spoken language communication. Another big domain that may be of interest to families is behavior. So some of the behavioral challenges that can happen: hyperactivity / ADHD, anxiety, aggression, irritability, restrictive repetitive behaviors, and so forth. Each of these can be a talk in and of themselves. So I won't go into detail too much in each of these, but just to emphasize behaviors. So can be such a prominent consideration for many families. So there's, in terms of different approaches for behavioral issues in Hive P2 disorder, I actually wanted to call attention to actually another unrelated genetic disorder called Felon Mcdermott syndrome, which I'm a part of. And we've created these, so we've formed this, what we call PMS, Phelan-McDermott syndrome, neuropsychiatric consult group using a Project ECHO model. Project ECHO is a initiative basically that allows different clinicians to talk to experts in a rare disorder, or in, for example, in this case, Phelan-McDermott syndrome, and discuss a challenging case, challenging from the neurobehavioral perspective. The clinical experts weigh in. It's a very collaborative type of interaction. It's asking a lot of questions and then coming up with a plan, some suggestions about how to manage different types of behavioral symptoms. The reason why am I talking about this in this talk? The reason I am is that through this Project ECHO model, through this PMS neuropsychiatric consultation group, we've actually formulated different types of algorithms and guidelines for approaching different types of neurobehavioral symptoms. For example, here is a flowchart that talks about approaches and medication approaches to targeting ADHD symptoms in Phelan-McDermott syndrome. And similarly, we've come up with the kind of expert-based guidelines about treating with medications irritability and aggression in Phelan-McDermott syndrome, and also as well as anxiety in this syndrome. And again, I think I bring this up not to say, that we should adapt these type of guidelines for Hive P2 disorder, but to mention that there are frameworks that we can, learn from other disorders and possibly see what may be working for other genetic neurodevelopmental disorders with similar set of challenging behavioral issues, and see if those similar approaches work for Hive P2. Again, showing these not to say these are or should be the recommended treatment approaches for certain types of behavioral symptoms in Hive P2, but to say that these guidelines, and experience from other genetic neurodevelopmental disorders which have complex neuropsychiatric manifestations. As a clinician, I learn and adapt and incorporate some of these very kind of principles when I'm seeing families with Hive P2 disorder. Oh yeah, please do. Yes. Yes. Mhm.
Sure. Sorry. A little background. So most of us, or I would say all of us, have an IEP at school. And of course, those are very complex, and many of the goals there are written. And I would say many parents don't always understand if those goals are adequate for the child based on where they are currently or from a developmental perspective. And some of us may have advocates that help us. Some may not. But with regards to that, is there a community of something like this where we could present, or our specialists, our OTs, our PTs, our speech therapists could ask questions to, or some type of forum where we could say, hey, are these goals developmentally appropriate for this? Or how have you learned anything, or what are things that we could do to implement in our school districts?
Right. So that's a really great question. So I guess to rephrase, let me make sure I'm understanding your question.
Yeah.
Your question is that, so is there a core group of, say, Hive P2 experts that schools or IEP team in schools, or even, the clinicians that is caring for a patient with Hive P2 disorder can refer to or consult with to say, hey, are these goals appropriate? Are there things that can be tweaked? Is that
correct? Or
yeah.
based on, for example, a team like this is experienced with neurodevelopmental disorders. Are there certain goals that we know have proven to be effective with children impacted by X, Y, or Z? I know we're such a strong community here on Facebook. Like many
Sure.
will reach out and ask, like, hey, what worked for your kid, or is there something else? But I don't know if there's folks from a medical perspective that see these type of similarities across many single gene mutations.
Right.
And if not, maybe it's an opportunity
Yeah, that's a great question.
in the future.
Yeah, no, not to my knowledge. Like, I'm not aware of such type of program, but I think it's a really good thought. I think it's a really good idea. I think right now it's mainly kind of families seeking out different clinicians who see rare genetic neurodevelopmental disorders, and getting their expertise and opinion on these, and having that clinician, work with the family and make suggestions about what can be changed or impacted with
if
the
anything
IEP.
comes up like that, it would be awesome for this community to know about it, because I know and I'm probably not the only individual, but our therapists at school, they're very interested, right? They're not trying to be rude, but they'll say, hey, Charlie's such an interesting case for me because we don't see many children like this come through the school district. And while they do a phenomenal job with the resources they have, if there was somewhere that we could, as parents, advocate for, reach out to, or connect, it would just be, I think it would take it to the next level in terms of care and opportunity.
Might I be so bold as to nominate you as the one to
Oh.
spearhead this initiative?
Maybe, perhaps. Thank you. Sorry for a tough
Yeah.
question.
So another, switching gears a little bit. So sleep is another challenge that may come across, or something that you may experience. Disrupted sleep is something that you may experience and can be a challenge for Hive P2 disorder. This can be issues with what we call sleep onset, which is problems with falling asleep. It can be an issue with what we call sleep maintenance, which is staying asleep. And this can be an issue with waking up early, waking up at 4 or 5 o'clock in the morning. When we think about disrupted sleep, we first really try to look for any kinds of causes of disrupted sleep. So we look for, could there be behavioral, environmental factors, something about the environment which the child or individual is falling asleep in? Is it dark? Is it noisy? Is it light? Is there other things, distractions in the room, TV, music, etc.? We see if there's any kind of behavioral challenges that may revolve around sleep. Is the individual not sleeping in their own bed because they want to get up and cuddle with their parents? Is there something like that that may be driving the disrupted sleep? Are there different types of mood states that may be associated with disrupted sleep? Anxiety can be, if one is anxious, then that can certainly impact, one's ability to fall asleep and stay asleep. Is there inconsistency in the routine that may be a factor in sleep? And for children, typically developing children with special needs, consistency is so important when it comes to sleep. Consistent routine, consistent responses to waking up at night. That's even slight deviation from that consistency can throw off one's sleep schedule and leading to changes in sleep that may last for weeks or longer. Are there medical factors like reflux, acid reflux, or other things, that pain in the legs or so forth? Could there be restless legs at night, or restless leg syndrome, that's preventing somebody, a child or individual, from staying asleep the whole night? And other medical factors like sleep apnea, which can present as snoring, and having apneas, which are pauses in breathing. There's different approaches to addressing sleep, disrupted sleep. We often start conservatively, starting with environmental changes, making sure there's a dark, quiet room, making sure there's a comfortable environment in terms of temperature. Sometimes kids don't respond to abnormal textures of clothes or tags on clothes or certain types of cloth in the pajamas. So even those simple changes sometimes can impact sleep because of sensory issues. Like I alluded to, routine is so important when it comes to sleep. I really emphasize consistency, consistent sleep schedule, consistent time you put the child to bed, consistent responses. If the child is waking up in the middle of the night, meaning if they're waking up and coming to your bed, do you bring them back to their own bed? Do you allow them to, cuddle with you at nighttime? Because once somebody learns, if you get up in the middle of the night and you go to your parents' room and you get to cuddle with your parents, then that becomes a very positive reinforcer for that type of behavior. Avoiding naps if possible, because if you are taking naps during the daytime, you may be less likely to be as tired and during the nighttime and fall asleep readily and stay asleep. Good old-fashioned exercise is good for so many things, but exercise, if possible, can be absolutely helpful for making sure sleep routine is good. And when I say positive reinforcements, what I mean is that if your child is at a level sufficient that they could understand a positive reinforcer. So for example, for some kids, if you could say, if you stay asleep the whole night, you'll get a reward the next day. So again, this applies to those who may be at a certain cognitive level to be able to, understand that concept of that kind of delayed positive reinforcement. There are, of course, medical treatments that we use for sleep. I've listed some of these, once again, not to say that these, this is what should be used, but these are just some of the breadth of options that can be used to address sleep, assuming there isn't a behavioral or environmental or medical factor that's impacting or underlying the sleep disturbance. The question of seizures or epilepsy comes up a lot when I'm talking to families. Just some quick definitions. So a seizure represents basically a abnormal synchronized electrical activity in the brain. So typically in the brain, the left and right side are doing, if you look at the brainwave patterns on an EEG, for example, you expect all these kind of random squiggles. But when you see synchronized activity, when you see the electrical activity synchronizing together, that can be the setup for a seizure. Epilepsy is a term, so what's the difference between epilepsy and seizure? So epilepsy is a term that we refer to when somebody has experienced 2 or more unprovoked seizures in their lifetime, at least 24 hours apart. So if your child has had a seizure when they were 3 and a seizure when they were 3.5 that were both unprovoked, meaning not clearly in the setting of infection or something like that, that meets the definition of epilepsy. Sometimes people use the term seizure disorder, I think, interchangeably for epilepsy. I think epilepsy is just a little bit more of a precise term, perhaps. There are different classification schemes for seizure. So there's and one classification scheme is based on where the seizure emanates from the brain. If the seizure starts from one side of the brain, we call that a focal seizure. If the seizure comes from both parts of the brain, both the left and right side, we call that a generalized seizure. And if we don't know where it originates from, it's of unknown onset. In terms of epilepsy severity, so I think generally speaking, we don't think of epilepsy as a huge component in Hive P2 disorder, but it can happen. It can affect some individuals, and in some individuals with Hive P2, it can be severe. So I think I think we need more data to make a little bit more claims about the frequency of epilepsy and the severity. But again, it is possible. Epilepsy can be possible in Hive P2 disorder. And if it occurs in Hive P2 disorder, there can be a spectrum in terms of the severity of the seizures, from fairly uncomplicated to what we call refractory epilepsy, which is seizures that don't respond to, that an individual has undergone 2 or more different trials of medications to control their seizures, and they have yet to achieve freedom from the seizures. Motor issues are common in Hive P2 disorder, so hypotonia or low muscle tone, and significant motor impairment to the point that some individuals with Hive P2 disorder receive the label or diagnosis of cerebral palsy or CP. Just a quick note about the term CP. So if a lot of people see CP and think brain injury or or decreased oxygen at delivery, but the term CP is really just referring to non-progressive motor impairment with onset in early childhood. So I think a lot of, just by that definition alone, I think it kind of makes sense. So I'm using the term CP more to refer this notion of non-progressive motor impairment with onset in the early childhood period. There's of course, physical therapy, which is something that you are probably familiar with, but 2 additional sort of maybe non-conventional approaches to help address hypotonia and motor coordination challenges for Hive P2 are hippotherapy and aquatic therapy. So hippotherapy is the idea of working with horses. So why does that help? Well, if you're on a horse, then it can help address, kind of build some of those core muscles, and may be helpful for some individuals who have significant hypotonia, significant motor challenges. the downside, I guess, is you have to be accessible, or the horses need to be accessible to you, and insurance many times will not necessarily pay for this type of therapy. So you're kind of, sometimes you have to, fight the insurance companies a little bit and have letters of medical necessity and so forth. And even then, it can be a little bit of a challenge for insurance to pay for it. The other thing to mention is aquatic therapy, or just even more simply swimming. I think that's a good type of activity that builds core muscles. It keeps muscles, keeps motor functioning going, and it's often a fun activity that kids may enjoy. So the last kind of big theme wanted to mention is, well, future outlook, where what is, I guess the big question is, will my child have the capacity to live independently in the future? And to answer that question, it really, to me, is anchored on what is the individual's IQ. And level of intellectual disability. So what is intellectual disability? So intellectual disability is defined as having an IQ below 70, and as well as significantly impaired adaptive or self-help skills. So feeding, dressing, toileting, and so forth. For Hive P2 disorder, so there can be a wide range of intellectual disability, from the mild side to the severe to profound side. So a mild ID is defined as having an IQ between 50 to 55 to 70. Moderate ID is defined as having an IQ between 35 to 50. Severe ID is defined as having an IQ between 20 to 35, and then profound ID is defined as having an IQ less than 20. One way of kind of thinking about IQ is, you can almost think of it, again, this is this is a simplification, but it might be helpful for some instances to think of an IQ as kind of like a percentage. So for example, if you have a 10-year-old who has an IQ of 50, you can think of 50 as like a percentage. So 10 years times 50%, which is 5. So a 10-year-old with an IQ of 50 may have the cognitive skills of a 5-year-old. Again, I think that's simplifying it a lot, but I think it kind of gets you a little bit into the ballpark of having the kind of the mindset to think about or interpret what an IQ means. In general, an individual who has mild intellectual disability may potentially be able to live independently with some supports. I think an individual who has moderate intellectual disability may need to live with help, with assistance, and an individual with severe and profound intellectual disability would not be able to live independently. So again, I think I do encourage neuropsych testing, usually through the schools, because sometimes it's easier to go through the schools than privately through insurance because of various logistical issues. Neuropsych testing or IQ testing is something that's probably best done after age 6, 7 or so. I think if you do it a little bit on the earlier side, sometimes there can be some challenges in terms of being able to participate or having fully reliable assessments of somebody's ability at that age. But I think a little bit older, first grade, kindergarten, first grade, a little bit later, that child may be able to participate more effectively in IQ testing. It's helpful for establishing a baseline, and over time, the school, every couple years or so, schools can sometimes repeat their evaluation to, see where if things are changing. But generally speaking, IQ is generally speaking thought to be stable over time. So there's no targeted specific treatment for, so no Hive P2 specific treatment for ID, at least not yet. And I think I would say that is one of our hopes or goals in the future is, can we have more precision medicine? Can we develop therapies that target cognition and behavior for Hive P2 disorder? So for now, until we're at that point, I think the treatment for ID is relying on special education through an IEP. I think one concept to just to emphasize is that sometimes it's very important to make sure that the school's expectations for you are in line with the child's or individual's intrinsic capabilities. So anytime there's a mismatch, meaning whether the school has higher expectations than the child or the school has lower expectations than what the child can do, and whenever there's an imbalance between those two, somebody's intrinsic capabilities and the school's expectations, that can lead to behavioral challenges, frustrations, sometimes can appear as, mood issues and so forth. So making sure those two domains are aligned, I think, is a very important goal. I'll mention ABA, so Applied Behavior Analysis Therapy. So ABA is a type of one-on-one behavioral therapy where a board certified behavioralist works with somebody focusing on social communication skills, focusing on addressing any maladaptive behaviors, focusing on self-help skills and so forth. ABA therapy is, in the US at least, is only available with an autism diagnosis, or insurance will only pay for it with an autism diagnosis, regardless of whether a physician says, oh, I think AB is medically necessary for this child who has Hive P2 disorder and intellectual disability, but insurance will only pay for it with that autism label. Okay, so just to wrap things up, what are some kind of lessons learned from seeing families over the couple of years of families with Hive P2 disorder? I think first and foremost, it's really important for us as clinicians and researchers to listen to the parents. I think I tell this, I learned so much from each encounter with the family. I think families tell us what we need to be focusing on. They help raise research questions. Oh, are you looking at the sensory component? Why does my child not perceive pain as much as, somebody should be perceiving? I think it's really important to kind of listen to you guys and to help so we know what we should be paying attention to. Secondly, I think, until we have more precision medicine, meaning until we have some, targeted treatments or gene therapies or those kind of high level interventions, we're targeting the symptoms, whether that's with services like speech and language, PTOT, or with behavior, with medications targeting behaviors. And I think we should, continue to collect, just learn from each other and find out, well, what are responses to different medications for anxiety in Hive P2 disorder? What are responses to different medications for ADHD and so forth? I think my sense is if we could collect that information now, and it's probably going to be all over the map. But I think with continued data collection and with continued larger numbers of individuals, maybe we can start to see some trends and start to generate useful clinical guidelines or advice that may be applicable to multiple families. The third concept, which is really alluded to by Alisa's talk, is that there is some common themes, but there's also so much variability, right? So if you looked at the graphs that Alisa presented earlier, there's wide ranges in these developmental profiles. And I think that emphasizes that every individual is unique, so even if you can take two individuals who have the exact same misspelling in Hive P2, and one could be mildly affected and one could be severely affected, and that's both fascinating and frustrating to have that realization. And ultimately, although we can kind of look at the disorder as a whole, as a group, at the end of the day, you have to look at the child and look at the individual child's or individual's strengths and capacity for growth. It's a marathon, right? It's one day at a time. It's hard to raise typically developing children, and it's exponentially harder to raise child with special needs. It's every day can be a challenge, and just I think taking it one step at a time is one approach or one guidance I suggest to families. And then lastly, don't estimate. What I remind myself or try to remind myself is not to underestimate each child's potential. I think these tools that these neuropsych and assessments, neurobehavioral assessments, sometimes they may not quite capture the abilities of an individual. With any sort of behavioral and psychiatric assessment, a big question is it a question of can versus will? Like, is it truly measuring a child's ability, is it a performance issue? Is it actually measuring what is supposed to be measuring? Are there other factors that may be impacting, like whether it's truly measuring what's supposed to be measuring? But anyways, I say this to say that sometimes, I hear from families that there's potential in their child, and we really just need to figure out better ways to unlock that potential. We're not too sophisticated in our approaches, but hopefully maybe that will change one day, where we will be a lot more sophisticated in unlocking each individual child's potential. So lastly, just to kind of acknowledge my mentors, Dr. Wendy Chung, Dr. Mustafa Seen at Boston Children's, a huge acknowledgement to the Simon Searchlight and Hope for Hive P2 and Nerissa in particular. And of course, the families, like I was saying earlier, we learned so much. I learned so much from all my encounters with the families. And truly, I think it's so inspirational to meet you and to learn from you and to develop our collective knowledge base about this very challenging and complex neurodevelopmental disorder. Thank you.
Alisa, Dr. Sid, thank you so much. That was incredible. As you guys can see from the graphs and the charts that are in the publications, this is why it's so important for families to participate in Simon's, to continue filling out the surveys, because there's a direct connection between the information you guys are providing and then what researchers are able to put together for us to better understand. So thank you both so much. And we're running a little behind schedule, but I think we'll be able to make it up with a quicker break. Sorry.
So sorry, I wanted to take a second because there were some really great genetics questions in the audience. So I wanted to make sure that everyone knew that our genetic counselors are available, and you can email and talk about your lab report and genetics with our genetic counselors at any time. So if you would like to make and this is free, this is part of Simon's Searchlight. So if you would like to email coordinator at simonsearchlight.org, you'll be able to sit down, talk about your report, ask about the pathogenic, likely pathogenic, and any of these other questions one-on-one, and have a great long discussion if needed.
Thank you, Misha. Okay, so next up is Dr. Charlotte DiStefano. She is going to talk about intellectual disability and autism, the diagnoses, and behavioral treatments. Thank you.
Thank you. All right, so since we're a little short on time and we're a small group, and a lot of this actually overlaps a lot with what Sid discussed, I'm happy to make this more of a conversation than an actual presentation. So please, I'm going to go through some information because I think there are some areas where I might have a little bit of additional information I can add, but I would love to stop and take questions or have a discussion at any point during this. So go ahead and jump in anytime, but of course, wait for the microphone so the folks on Zoom can hear your questions. Okay, so I don't know how many of you guys were at my talk yesterday. I'm a clinical psychologist. I actually started my career as a special ed teacher, so I know a lot about the school system as well. And as a clinician, I do a lot of diagnostic evaluations for kids with neurodevelopmental disabilities and make treatment recommendations. As a researcher, I do a lot to try to understand how we can best measure abilities in kids who have more significantly impacted cognitive and language abilities that we don't do a great job of measuring with our traditional assessment. So I think a lot about the limitations of assessments that we have, how we can best use that information. So I wanted to talk to you guys a little bit about the diagnostic process for autism and intellectual disability, although I feel like since most of your kids are older, you've probably been through this. So I'll just make kind of a couple points and go through this quickly. So you all know probably that autism is diagnosed based on deficits in social communication and interaction, and then the presence of restricted and repetitive patterns of behavior. what we're looking for in an autism evaluation is both the presence of atypical patterns of behavior and the absence of more typical social behaviors that we would expect to see. So sometimes psychologists will talk about this as positive and negative behaviors that we're looking at. Autism symptoms are going to manifest differently depending on the child's age, developmental level, expressive language level, their sex or gender, cultural background, the context. If I'm evaluating your child in my clinic and they've never been there before, that context is going to impact the sorts of behaviors that I see. So it's not straightforward to diagnose autism within kids who have a more complex history. I'll skip over some of this stuff. If we're doing a full evaluation, if you guys are coming to see me in clinic, we're never looking for autism symptoms in isolation because, like I said, you can't really evaluate autism symptoms in isolation. You need to know what the child's cognitive testing shows, what their language abilities are, adaptive behavior. We usually look for additional things like ADHD, anxiety, which the clinical term for that is comorbidities, just meaning other concerns that are happening at the same time. And then we usually want to try to get reports from the teacher or reports from outside therapists to get a good understanding of how the child is functioning across different settings. I'm not going to talk about the specific measures, but I'm happy to go back to this if people have specific questions about it. Okay, and then I want to talk quickly about intellectual disability because it's not a fun term. Nobody likes it. Nobody wants it applied to their child. What I say to families in clinic, the way I try to explain this is, like Sid said, intellectual disability is describing a difference between where that child is at developmentally and where typically developing kids their age are at. It's describing that gap. So it doesn't mean that the child is not capable of learning. It doesn't mean that they've sort of hit some ceiling and they're not going to develop any further. It just means that there is a gap between what they're able to do and what typically developing kids their age are able to do in terms of cognitive tasks. So don't be afraid when you see this diagnosis applied to your child. It doesn't mean that they're never going to learn and grow and be able to do anything else. It's just describing that difference. Yeah.
I don't know if this is best for you or Dr. Sid's team, but in terms of children with single gene mutations, when we talk about ID and learning capability, are we seeing that of the older kiddos that you guys have worked with, that there's a point where they plateau and then they've kind of met their full life capability in terms of cognition? Or are we seeing that, hey, guess what? They may be a slower out the gate, but they keep learning and growing cognitively daily. So I'm asking this knowing I don't even know when our typical human brain stops learning or growing, or if it does, but I just wasn't sure if you saw patterns or had any insider knowledge into children with single gene mutations that are similar to Hive P2.
Right. So it's really, really variable is unfortunately my answer. This is a little bit of a tangent, but I think that I get frustrated sometimes as a clinician in this field. As a scientist in this field, I find it all very fascinating and I love learning about all the different gene disorders that we're starting to identify and their specific profiles. But as a clinician, I get frustrated because we're definitely further ahead in our ability to identify these different genetic disorders than we are in our ability to understand what might be special or unique about them and how we might have individualized treatments or individualized expectations based on those disorders. So I see lots of families in clinic who have a variety of either single gene disorders or chromosomal disorders associated with autism and neurodevelopmental disabilities. And everyone wants to know, okay, you must know for my kid's condition what the best things are to do and what we can expect. And the reality is we don't actually have those answers. The best answers I can give you are the ones that apply to everybody with intellectual disability, whether we know their genetic cause or not. Because unfortunately, we just haven't really gotten that far in understanding the different profiles. So all of that to say that, yes, individuals with intellectual disability, assuming that we're measuring it correctly and we're diagnosing it correctly, they are at some point in early adulthood going to reach sort of their developmental point of the most kind of complex conceptual information that they're going to be able to understand. Yeah, and understanding abstract concepts like, you know, I don't know, civil liberties and the right to vote, and those sort of more abstract concepts that for individuals with intellectual disability are probably always going to be a bit of a challenge to kind of grapple with. But that brings me to exactly what I wanted to talk about next, which is severity levels in intellectual disability. Dr. Sid was mentioning the IQ ranges for intellectual disability. That actually isn't the system for classification anymore. That was previously when we had what was called the DSM-4. And there was a big effort to reconceptualize how we think about levels of impairment in intellectual disability. And because our individuals are not great at sitting down and taking cognitive tests, it doesn't seem like that's the best way to categorize people. Also, IQ tests don't go down to the 30s and 20s. So there was never actually any way to get an IQ score that low. And so we've scrapped that system. The criteria for severity levels is now supposed to be based on your actual functional day-to-day skills and impairments. It makes the lines a little bit fuzzier. So what I call moderate ID, someone else might call severe ID because it's a bit more of a judgment call. But at least then it's based in what an individual is actually doing on a day-to-day basis, not just the number on the test. But all of that to say that in terms of what we think someone is going to need as an adult, once they get to 10, 12 years old, and we can get a good sense of what their level of intellectual disability is, that's sort of the best predictor, not what their genetic etiology is, not what the specific syndrome is, but where they're at in terms of their cognitive development trajectory. That's going to be the best predictor of, you know, when are they going to sort of reach their plateau for their abilities and what sort of supports are they going to need as an adult. So I would encourage you to conceptualize it that way. I hope that someday soon we will have answers that are more specific to certain genetic etiologies, but right now that's where we're at, especially given that, as Sid's data was showing and we found in other disorders, even with the exact same genetic mutation, we have kids who are all over the place in terms of their ability. So it doesn't seem like the specific genetic change is actually leading to a really, really specific set of abilities. There's still a lot of variability there. That's a great question, though. Thank you. Yeah, please.
I don't know that you'll have an answer to this, but based on what you know in terms of wide range of capabilities, even with the same mutation. So say you had a set of twins and they had the same mutation, you may see that one of them is growing at a faster rate than the other. Do you know, have you guys seen why? Or even kids, the same kids, is it one? We have no idea why.
I have no idea why. I wish I did.
I'm
Check back
asking
with
the
me in
impossible,
30
I know.
years. The disorder that I work with most closely is called DUP15Q syndrome. It's not a single gene disorder. It's a range. So there are multiple genes involved. But we're grappling with the same thing, and that group is a little further along than you guys. We have a much larger data set, and we still haven't really found any clear pattern for why certain kids seem to have a pretty high developmental trajectory and are gaining lots of skills, and other kids just kind of stay with really limited skills for years and years and years. So no, I'm sorry. We're working on it. And yes, everybody, please feel free to jump in. I'd much rather have a conversation than just give a lecture. Okay. So, this is one of my pet peeves. So I just like to point it out to people. The difference between global developmental delay and intellectual disability. Technically, global developmental delay is a diagnosis that only applies up to the age of 5. And after the age of 5, if the child is still globally delayed, then we start calling it intellectual disability. It's really not a different diagnosis. It just means that under the age of 5, there's so much variability in development that people don't quite want to call it intellectual disability yet. Even though practically we know that the majority of kids who have a diagnosis of global developmental delay are going to meet criteria for intellectual disability later on. So again, most of your kids are older, so this is not an issue for you, but I find it really frustrating when people give a diagnosis of global developmental delay, but never talk to the family about the fact that in a few years, your child's going to meet criteria for intellectual disability. We know that that's okay. Nothing has gone wrong that term is coming up. Yes.
As a special educator as well, when we're talking GDD versus ID, when
Yep.
the child, and there are some younger families here. So when the child gets to school age and you're at the point where you now need to move and kind of tick a box on that IEP regarding ID, medical diagnosis, et cetera. I know what we chose for our family to do, and every family may be different on that. Is there a recommendation that you have of an age of what you should check when? Because I know that like for this group, we could all check medical, and maybe this relates to testing your child for IQ or not having them tested earlier. Right. I was just wondering what your recommendation or maybe not feedback would be to the younger families that are just starting this process.
Yeah. Do you want to add something before I answer?
Sorry, I know that you're specialized in special ed too. So I'm a kindergarten teacher. And so, and at least in my district in Pennsylvania, developmental delay is not acknowledged as something that you can get an IEP coming into school with. So we didn't know what to do because I knew that my son needed help, a lot of help coming into kindergarten, going into kindergarten. So I went straight to my PCP recommended us to go to a neuropsychologist to get tested strictly for a diagnosis. And when we went, he was diagnosed with ADHD because ADHD will get you an IEP, at least in Pennsylvania. So we had to go that route just to get him an IEP, which got him all the help he needed until he was tested, that IQ tested and tested low, but the district didn't want to, actually the neuropsychologist said she wasn't like happy with that test. And so she wasn't able to perform a lot of the tests on him. So she went with ADHD rather than intellectual disability or anything like that. So ADHD though got him his IEP.
Yeah. So for those of you who were not in my presentation yesterday, special education is a little bit quirky because in order to qualify for an IEP, the school district has to find that the child is eligible in these specific disability categories that are defined in federal law. Like they have nothing to do with what I as a clinician would put as the categories. It's a bizarre set of categories. It does have autism. It does have intellectual disability. In some states, if special education starts in preschool, they do have a global developmental delay category for preschool only. There's also a category called other health impairment, which is where sometimes kids with a genetic disorder will land. It's where kids with ADHD land. It should not matter what the eligibility category is. Is that practically always the case? Not necessarily, but in terms of the way the process is supposed to work, it doesn't matter what the eligibility category is. That sort of gets your foot in the door to say, yes, this child meets criteria to have an IEP. Okay, now let's figure out what their needs are. There really should not be any relationship between the eligibility category and the services that are given. Not that that doesn't ever happen, but you should go into it sort of agnostic about the eligibility category. I don't care how they decide a kid qualifies, whether it's autism or intellectual disability or speech and language impairment or other health impairment. I don't care which one it is, as long as the services that they're getting afterwards are appropriate. You will sometimes run into school districts, I think maybe smaller school districts that maybe don't have as many different programs and as much flexibility, where they might sort of see the eligibility category as a signal for what the child's level of need is. So a child with autism or intellectual disability might be seen as having a higher level of need than a child with speech and language impairment or ADHD. And so if you're seeing that, then absolutely advocate for a different eligibility category. But other than that particular situation, it really shouldn't matter.
Charlotte, I'm just going to add one more thing too.
Yeah.
So in criteria for Medicaid waiver programs too, sometimes the intellectual disability diagnosis is important, especially, each state is different. We're in Florida, there's like a 20-year wait list for the Medicaid waiver program. You can't apply until you're 3, but when you apply at 3, you don't have an intellectual disability diagnosis, so you can't qualify to get on the wait list. So those are some things to also consider. If you're able to get IQ testing prior to 5, some people can do that, and that can help in that case.
Yeah, I think there's, I'm kind of jumping ahead. I have some slides on this way at the end of my talk, but how we think about making these diagnoses from a research and science standpoint versus the more pragmatic clinical standpoint. I can talk to you all day about how concerned I am that we're over labeling kids with autism when they have really low levels of cognitive skills, because our measures are just not good at differentiating those things. As a scientist, I'm very concerned about that because it changes our research. As a clinician, if I can justify the diagnosis, I will give it because it will help that family access services. So from a very pragmatic standpoint, I would say take all the diagnoses that your kiddo meets criteria for. Does it mean that the child really has autism and intellectual disability and anxiety and ADHD? No, not at all. They have one neurodevelopmental disability caused by this specific genetic change, and we're labeling parts of it. But because of sort of how our service landscape works, you have to have all those labels to get access to the different services. So what I usually do when families come to me for a comprehensive evaluation is I tell the parents, okay, like don't get overwhelmed, but I'm going to go ahead and call out every diagnostic category that I see that your child meets criteria for, because I want you to have that as backup for, justifying why you need various services and getting on Medicaid waiver lists. And in California, it's all about getting regional center services. And, if they have a diagnosis of intellectual disability, they're going to qualify for some services that they wouldn't otherwise. So I would rather go ahead and give the diagnosis if they do meet criteria for it, even if I think the measures are flawed and they probably have more skills than we were able to evaluate in the clinic visit, just because pragmatically it'll help you in the long run. So make sure that your providers are giving you those diagnoses and documenting them. Okay, in terms of diagnosing autism specifically in the context of intellectual disability, like I said, we need to be really careful about how we conceptualize autism symptoms. Most of our autism diagnostic measures are considered to be valid only when a kiddo has reached a level of a typically developing 18-month-old in terms of their development. And so for some of our kids with more limited cognitive skills, they're not really actually at that level. And so we need to be very careful about how we interpret their skills. Essentially, so for kids who are in the more mild to moderate range of intellectual disability, our standard autism diagnostic measures function just fine. We think that they're valid. We use them the way we would for anybody else. For kids who are more in the severe to profound range, we don't have really good options. We don't have measures that are specifically designed for them. And so what we as clinicians try to do is make sure that we're interpreting the child's social communication skills relative to their overall developmental level. So if I'm working with a kiddo who has an overall developmental level around age 2, if I'm trying to say, you know, okay, I think this kid has autism, they have a social communication impairment, I want to see that their social communication skills are impaired relative to expectations for a 2-year-old, not relative to expectations for their chronological age, because then of course they have social communication impairment. So that's the thing that we have to think about for our kiddos with more limited cognitive skills. We already talked about that. Okay. So this, what time is it? Okay, I'm going to skip through some of this. So you guys, a lot of you have older kids, you kind of know the service landscape. At school, your kids are getting whatever the classroom curriculum is or their individualized curriculum. They might be getting speech therapy, occupational therapy, maybe participating in extracurricular activities. And then you might have some services at home, kids who are doing behavior therapy, that's often happening at home. Maybe you have respite services. And then we talk about clinic-based or private services. These are often accessed through insurance. And these are all the other therapies that you might be doing outside of those contexts. We talked about this yesterday, so I'll skip through this stuff. Sorry, the clicker goes slow. I want to talk quickly about behavior therapy. So for kids who have an autism diagnosis, there is an insurance mandate that says your insurance has to cover behavioral therapy services. For kids who don't have an autism diagnosis, it varies by state how you might try to get these services covered. In California, if the child has, for example, just an intellectual disability diagnosis, but not autism, we can often get these services covered through what in California is called regional center, which is the public payer. But it varies state by state. But lots and lots of kids with these rare genetic syndromes are getting behavioral therapy, whether or not they have a diagnosis of autism. It's just easier if you have that diagnosis documented. So I get a lot of questions about types of behavior therapy and what's the best type and what we should be looking for. So we think about behavior therapy as being sort of on a continuum from a more adult-led, directed style of therapy to a child-led, play-based style of therapy. So on the adult-led side, we see what we consider this more kind of old-fashioned original version of applied behavioral analysis, which is discrete trial training. And there are old videos of this that I think are even on YouTube that you can watch with Lovas, who designed this. But this is the very directive, practicing the same skill over and over, the adult sitting there, the child's at the table, the child's told to pick up the blue card over and over and over again, and every time they do it correctly, they get an M&M. That's the very old discrete trial style of ABA. Since that time, people have been increasingly interested in more naturalistic, developmentally appropriate versions of behavior therapy. So we have things like pivotal response training, PRT, Early Start Denver model, Jasper, which was developed at UCLA. And those are all collectively called naturalistic developmental behavioral interventions. So meaning that they are more play-based, ideally matched to the child's interests and their developmental level. There's going to be a lot more playing with toys, sitting on the floor and doing collaborative activities, but still working towards specific targeted goals. And then all the way at what I would consider the very child-led end of the spectrum is something called floor time, which I think is a little more popular on the West Coast than the East Coast. Floor time is, oh, I thought I had another slide there. Maybe it's on here. Okay. There we go. Floor time is not considered a form of ABA. All of the rest of the acronyms that were up there are considered a form of applied behavior analysis. Floor time is sort of outside of that umbrella and is all about building relationships, following the child's lead. It doesn't have as much of a research backing as forms of ABA do in terms of making change. But some parents like it better because they feel that it's a more positive style of interaction that their child enjoys more. So like I said, something that is more adult-led, like discrete trial training, is usually seated at a table, led by the adult. It's targeting individual skills and using directive strategies with frequent reinforcement. So the adult is going to give a specific prompt, tell the child to do something. They're going to do it. If they do it correctly, they get a reward. If they do it incorrectly, they get corrected, and then the trial starts over. Something like pivotal response therapy, which was developed by the Kegels at University of California, Santa Barbara, is play-based, but the child initiates what they're interested in playing with. And so the therapist is then going to follow along. The child wants to play with magnetiles. The therapist is going to join in with magnetiles. But the therapist still has some very specific things that they're targeting. And once they get into that routine playing with magnetiles, then the therapist is going to start doing things that feel more like the DTT style. So they're in the middle of playing with magnetiles, and then the therapist is going to hold up 2 magnetiles and say, which one do you want? And if the child correctly labels it, they get the magnetile. If they don't correctly label it, the therapist is going to correct them and they're going to try again. So there are these little trials embedded in a more naturalistic play interaction. And then when you go a little further on the spectrum, you get to something like Jasper, which, like I said, was developed by Dr. Kassery at UCLA, which is where I did my PhD, so I know it quite well. Which is play-based, child-initiated, and where we don't have these sort of embedded trials. Instead, we're working on promoting engagement and getting the child to initiate more communication, initiate more play activities. And the therapist will have in their head kind of what their targets are and what they're working on, but you won't see those specific trials embedded in the interaction. All of this to say that this specific acronym is less important than that you feel like there's a good fit between the therapist and your child. So a lot of parents want to know, which is the best style of behavior therapy? What should I be looking for? And I really encourage people, in general, we think that this more adult-led directive style can be very helpful for establishing a brand new skill that the child doesn't yet know how to do. And these more play-based, child-led styles of interaction are going to be better for generalizing skills, for practicing skills that they've started to do and just need to get better with. But at the end of the day, if your child has a good relationship with the therapist and you see the child making progress, I don't care which acronym the company says that they're using. It really, really does not matter that much at the end of the day. I'll say one quick thing about measuring progress, and then we will wrap up. A lot of our kiddos perform what we call at the floor of standardized assessment, meaning that whatever the lowest score is that you can get on that assessment, that's what our kiddos get, because their skills are not within the range that that assessment is designed to measure. Because assessments are designed to measure skills in typically developing kids. That's what the norming population is. That's how these assessments were developed. So if your child is 10 and they're doing a traditional cognitive assessment and IQ test, that score is going to be based on expectations for a typically developing 10-year-old. So if your kiddo is not there, then that score isn't super helpful And we end up with kids getting scores that are at the floor, which is a problem for research because then everyone's got the exact same score and that's not very helpful. But it's a problem for you guys as parents because then you don't know if your child is really making progress over time. So again, something I like to make sure parents are ready for is that, so Dr. Sid was mentioning that IQ stays stable over time after about age 6 or 7, which is true for typically developing kids, and it's true for kids who are in the mild range of intellectual disability. But for kids who have lower scores, we actually sometimes see scores go down over time, not because the kid's losing skills, but because the gap between where they're at and where a typically developing kid of the same age is getting bigger. So if your kiddo takes an IQ test when they're 5 and the score is 60, and then they take the same test when they're 10, that score might now be 45. And it doesn't mean that they lost skills or got worse. It just means that that gap between them and their same age peers got bigger. So that's something to just be prepared for. You need to have these tests so that you can make the diagnosis and give it to your insurance company. But they're not the best way to actually measure progress over time. So this is just an example. This is a kiddo who I assessed. This is a kid with Dup15q syndrome, I think, who I assessed 2 years apart. And you can see that their standard scores stayed exactly the same because these are the scores at the floor. This is the lowest score you can get. And so if you would just look at the standard score, you would say, well, this kid hasn't changed at all. They're exactly the same as they were 2 years ago. But if you look at the age equivalent, which tells you what sort of developmental age this child's skills correspond to, you can see that they've actually made quite a lot of progress in some of these domains. Their receptive language, when they were 42 months old, was at the age equivalent of 9 months, meaning that they weren't really showing they were understanding anything. And when we tested them again 2 years later, that was up to 15 months. So they had made actually, for a kiddo with severe ID, really, really nice progress in that area. And we wouldn't see that if we looked at the standard score. So just the professionals who are evaluating your kids and working with you should know these things, but just something to keep in mind. These tests are not designed for our kids. Sometimes we have to use them anyway, but we have to be creative with how we look at the scores to make sure they're meaningful. Okay, I think I'm gonna stop there. We're supposed to have a break, but I'm happy to take some more questions if you guys have them. But also feel free to go get coffee if that's what you need to do. So first of all, thank you. This was fabulous. I love your kind of philosophy and approach on things. So my question is, when it comes to getting services, we don't have all of the diagnosis that we need. So we're struggling to get some of the services. It's not an insurance thing, it's a state thing. Okay. And I feel like we've gone through all of the traditional ways and we're still kind of struggling. I feel like there's got to be some way around it or some loophole or something that we don't know about. So for folks that are struggling with getting some of the services through the state or for the state laws or whatever, how do you recommend or what approaches, tips, tricks, who can we work with to kind of help us figure out how to get the services we need? So this is kind of a strange recommendation, and I don't know if it's going to work or not, but here's my suggestion. I would find a university in your state that has some researchers who do work similar to what I do, who are more on the like psychology side of things, not on the medical side of things, because they don't necessarily deal with the same issues that we do. It doesn't matter if they work with the same disorder, just as long as they're working with kids who have more severe needs and that they do assessment, and ask them for advice about what works in your state, because it ends up being so specific. And I know that if anybody contacts me anywhere in California, I know how to help them navigate and what offices they should call and what type of documentation they need. And I know colleagues in certain other states and certain university programs who would have the same knowledge within their state. So I feel like that might be a place to start. Yeah, I love it. Thank you. You're welcome. So I'm specifically talking ABA. So our insurance will cover ABA, but Iowa like won't let us do ABA without an autistic diagnosis. So we were getting services in Texas, but we can't get them in Iowa. Oh yeah, there's tons of documentation, but it just, people haven't lobbied hard enough. And for some reason, it's just not required yet, the same way it is for autism. So your insurance company will cover it and the state of Iowa says, no, thank you. Correct. Eric, oh, sorry.
I was just going to say, do you have in your community a group like an autism support group? Because those are the people that have run in the same exact problems you have. It's kind of like our group here, but ours is, around the world. But if you have a local one, those are the people that are going to help you navigate the system because they know they're in the same exact boat you are in.
Yeah, I'll have to try that. There's only one like ABA, like applied, or I don't remember the name of it, but there's only like one ABA like clinic. And they're the ones that are not being helpful.
Okay.
So,
But it's like other families that are in your area that would know that.
yeah.
Those are,
I've got to find some families. Yeah, no, that's a great suggestion.
yeah,
So
because it's,
does your child have an autism diagnosis
No,
documented anywhere?
She does not.
Do you think she meets criteria for one?
I mean.
That's one
no,
solution to the problem.
No, but they consistently say
Okay.
no. We keep
So,
asking.
okay, so you have gone that route. Yeah. Yeah, I would also look for maybe other rare disorder groups in your state, that might have families who have similar issues. Because obviously you guys as a group are pretty small, but there are lots of other groups who have overlapping issues who might be a little larger and more established where you might be able to get some advice. Yeah. Awesome. Thanks, guys.
I actually want to add on that and just ask the room, how many in the room have an autism diagnosis for their child? 1, 2, 3, 4. Yeah, and so more don't, right? Yeah, and I think that this is part of why I was so excited for this talk, because all of our children have some form of intellectual disability, and I feel like that complicates trying to get an autism diagnosis. I think that there's no harm in pushing to test, and if it comes back borderline or without a diagnosis, at least you tried, just because it opens the door to so many more things.
Go ahead.
Oh, I've had a hard time also. Well, we were told that my son is too social to be autistic, but he like fits the criteria perfectly. But also with like getting him help with hyperactive, like we live in a small area and nobody will prescribe him medication because he's Hive P2. They will not touch him. So here we are with a little boy who is going so fast mentally, physically, and we have all these I'm going to cry. I have all these therapies that I'm taking him to every day and every other day, and he's not absorbing any of it.
Right.
He's not advancing because he's going too fast. And at the same time, nobody will help us.
So it's a little frustrating. This goes back to what I was saying earlier about how we're further along in our ability to identify these genetic syndromes than we are to do anything specific for them. And sometimes physicians, psychologists, therapists, everybody gets a little spooked and they say, well, that's different than autism. That's different than intellectual disability. That's a specific genetic disorder. You have to go talk to a specialist. And that there can be some specific considerations that need to be made. But a lot of the things that we know work for idiopathic, all of these things without a genetic diagnosis still work, even if we've identified the specific genetic cause. And so again, what you were saying about Geisinger, even if it's far away, I would encourage you to try to get a consultation with someone at an academic medical center who can then write some specific recommendations that you can take back to your local doctor. We do that. So Dr. Jesse is a neurologist. She and I work closely together at Children's Hospital Los Angeles, and we have what we call a Neurogenetics Clinic, where we see kids who have some sort of genetic diagnosis in addition to their neurodevelopmental disability. And a lot of what we end up doing, families come from far away to see us. And a lot of what we end up doing is just writing recommendations and saying, yeah, do all the things you would normally do for autism and intellectual disability and ADHD and anxiety. Take this back to your community provider who's worried that they're not doing the right things, and go ahead and do those things. That's going to be the right thing to do. And sometimes that's what it takes to move forward. So it's not that you're going to then have to go to Geisinger all the time for all your care. It's just to have somebody sort of put their blessing on it and say, yes, it's not dangerous to use the same medications. Go ahead. I will. The folks at Geisinger are fantastic.
I just want to echo the same thing, that as a clinician, and Dr. Sid and I both see neurogenetics folks who come from out of state, out of the country, and we write, and sometimes we're not their primary neurologist. They have a primary neurologist in their home, and then they come once a year just to get our blessing and write, get a list of the things that we would recommend, and they show it to their neurologist or their school district. The second thing that I'll say is that I would just have an honest conversation with your neurologist or your developmental pediatrician or whoever is trying to make that diagnosis of autism with you, that look, there is some, the diagnosis of autism, there is leeway in how you interpret different criteria. And so if you're just honest and say that there's, you need the services, and without the autism diagnosis, you can't access the services. There's a potential for some tipping the scales towards one. And I'm sure you've probably done that already. And but just for everyone else here in the room.
I was going to say as well, like, I'm so fortunate to live 10 minutes down the road from another member in our community. And what we've done is really partnered together. And if one of us has found a really great specialist or therapist or doctor, we've kind of come together and we both go see them. And that doctor is so thankful as well, because they can say, okay, while these children are all very different and while they have different capabilities, I see similarities in them, and it helps them help diagnose. Or if you've gotten something, then it's easier for them, or they feel more comfortable to advocate and help your child out. In addition, I was going to say, with an IEP, I've gone to our geneticist, one of the geneticists that we've worked with. And when I've struggled to get some services, I've had them write recommendation letters to also help explain a little bit more in depth the neurodevelopmental, or specifically with, Dr. Wendy Chung, Hive P2, that says, here's why this child would benefit from XYZ. And it takes the fight with the school district right out of the situation.
Okay. With that, we have 4 minutes left before Dr. Chung's going to start. So if anyone needs to take a super quick break, thanks.
All right, we're gonna jump back into it because we're a little behind schedule and there's so many great questions. I know people have been holding some of their questions. I really am hoping we'll get a good 15-minute block to ask the rest of your questions. But I'm thrilled to introduce Dr. Wendy Chung, who's going to give us an update on the Hive P2 natural history study and the information that they've collected.
Thanks, Nerissa.
Let's see, can everyone hear me? Is this okay? Okay, great. So feel free to ask me questions as we go along. I'll try and fill in some of the gaps from the meeting either yesterday or today as we're going through. And this is very informal. I am trying to do things for folks at home, some of the scientists and the families. So some of the comments will come in that way. So I think most folks heard me say yesterday that we've been at this at Simon Searchlight for about the last 12 years. Just to give you a sense of our dedication in the community, we're not going anywhere. So as we do this, we really are trying to help families help other families, as well as to have families work with researchers and researchers work with families. We're trying to be that glue that keeps the group together. Just so it's very clear, the Simons Foundation, as we do this, we don't sell your data. So we don't sell your data to pharmaceutical companies or anything like that. We don't ask you for donations. So we're not going to come around at the end of the year and ask you to pony up. This is all done completely free of charge to any of the family groups that are doing this. And as we're doing this, the only thing we want to do is support working with you. So I mean that I know it feels like, oh my gosh, can you believe that that's real? So believe it, it's real. And like I said, I'm very privileged to be able to work with the team for doing this for the last 12 years. As we're doing this, just to give you a sense, and I'm always impressed at the number of people you've seen, sort of these people running around like crazy people. So these are the people at the foundation who have been working, and many of them are actually not even here. They're behind the scenes at home working with us for all of this. But like I said, this is a huge team of scientists at the Simons Foundation, much less the other scientists that are around the world who are working on Hive P2. So just know that you're not alone. Either you've got, besides having each other, you've got a huge team of really smart, dedicated people working for you as well. Okay, as we're doing this, we are trying to think about a few different things. Number one is, and I'll warn you in terms of, this is not a one and done study because this is, your lives are not one and done. So this is not as if we just ask you one time. We need to understand as a community how things are changing over time. Things are changing over the life course, and in a good way, things are changing as new opportunities are available, as new technologies are developed. Sometimes it's because there are pandemics that are around us, but for whatever reason, things are changing over time, and we need to understand how that changes. And so just to warn you, if you filled out surveys and been part of this, it's not the last of what we're going to ask you to do. We try and minimize the burden in terms of this, but we do keep coming back. With this, we also learn better ways of asking questions. We learn new questions that are coming up from you all. And so this is an iterative process that continues to evolve. And we've been doing that since day one, but we'll continue doing that. And I hope, as I alluded to yesterday, get to some other things that are even collecting data in new ways. So not just filling out surveys, but for some of you who have been doing research, either on the first or the third floor, it's collecting other types of data, even things like EEGs or movement and seeing how our kiddos are moving, or in some cases, blood samples. But this will not be the last of those times that we do that. And it's because I'm thinking for us years down the road in terms of what we need to do to test out new treatments. And so all of the things that we're starting to do within that is with in mind trying to do what we call clinical trials, or thinking about being ready for clinical trials in the future. Okay, so as we've been going through this, to give you a sense of what's involved, we are doing this internationally, and we've tried to very much be as accessible as we can to people around the world. That means lots of interesting things in terms of having people that work weird hours of the day. And that's because for some of them, they're located in Europe, or some of them, they're located in different places in the United States. We also support multiple languages. So in terms of doing this, for each language, we have to go through a whole process. So we can't bring on 20 languages all at one time, but we've been trying to do by frequency. So what are the languages that we see most in terms of the community, and with input from Nerissa and other family leaders be able to address that. And so it goes way beyond just English and Spanish, just to give you a sense. It's not easy to do that, but we're very committed to doing that wherever folks are located. As we're doing that, we also want you personally to get something out of this. And so I'll be talking about the ways that we do this, but we also have a team of genetic counselors who are incredibly bright, dedicated, and knowledgeable. And so we include this as the first part of the journey, or the second part of the journey, actually, being able to talk to those wonderful genetic counselors. And it's a bi-directional conversation. Us being able to understand what your journey has been so far, but also you often have questions for the genetic counselors. And so it's a good way for you all to be able to also have that conversation going back and forth. And as I said, we're committed to continuing to do that, but also make it easier for you all by doing some things where you can do them online if that's easier. This is what we actually give directly to you all in terms of when you're filling out some of those instruments or those surveys online. As you're doing that, we have individual reports that go back to you. They don't go back to anyone else, but they go back to you, so that if you want to take that to your educator, to your IEP meeting, to your pediatrician, to your neurologist, you can actually bring that back, and you don't have to fill out those same questions over and over again, or they can get a quick snapshot in terms of how your child is doing developmentally or in terms of behavior issues. And I'm going to go over the aggregate results, the results from the whole Hive P2 community today. The other part of it is, like I said, that aggregate. So we also have what we call research snapshots to be able to see how is the whole of the group doing. And what I find families often do is say, oh, now I can see how the Hive P2 community, now how is Johnny doing in relationship to that? You know, is Johnny having, and what can I look forward to, or what can I be sort of watchful for as we're going forward? And so we try and do that in a way that's not gobbledygook in terms of medical jargon or scientific jargon, make it very accessible and understandable. If we're not quite hitting the mark, let us know. So any of the folks that you see around, let us know how we can do that better. And always feel free to write into us by email as well. Okay. Within this, some of you have also been giving blood samples upstairs, right? And you might say, what are those folks doing with that blood? So number one, thank you. I know it's not easy. I do think we've brought together like the world's most talented phlebotomist, I think, in terms of being able to do this. Hopefully it's been a good experience for you. What we're trying to do is scale your contribution. So again, it's all de-identified. No one knows who you are, but as we take that blood sample, it literally flies to our central location, and folks are making that into something that we call induced pluripotential stem cells. You may have heard folks mention that, but it's a way of being able to take a blood cell and make it into a brain cell without having to do something like a brain biopsy, right? We don't want to have to do that. But if we want to test a new medication or a new treatment, we want to have brain cells to do that on, and we want to see if it's going to work for your child. And so this is a way of making sure your child is not left behind, making sure they're represented. And for each time that we do this, each one of these cell lines that we make, this is, just to give you a sense, about $15,000 that we're investing. So this is no small amount of money that we're investing in terms of each time we do this. And as we do this, we can then make it available to researchers around the world. And your child doesn't have to get poked multiple times. They can just literally order this from our central location and be able to get that shipped to them. So it's a way of being able to, as I said, scale your investment, if you will, to make sure more people are working for you. So here are the data that I'm going to show you today in terms of what we've been collecting from the registry. And I'm going to try and show you how many I'm talking about so you can understand if it's something you should believe in or if it's something that we need more information as a community to understand. So let me start here. So this is the number of individuals so far that we've had registered on Simon Searchlight. It's not to say that there are only 43 people in the world with Hive P2, right? We know there are more out there. I know life is busy and life is complicated, so everyone hasn't registered. But I do think it's in our best interest as a community to stand up and have our numbers counted, right? Because when people go to say, where should I invest in doing research? Or if I'm a company that wants to develop a treatment, should I put X, Y, or Z? Are they going to pick a condition with 43, 430, or 4,300? Right? They're going to pick where there's a bigger market and they can make more money. So we want to make sure that we stand up and have our numbers counted in terms of that. So if we can do that, get the word out, tell a friend, let it be known on Facebook, however we need to get that word out. We are doing our best to make it as easy as possible to do, but I can't make this stuff up, right? I can't, make up a friend that you have on Facebook to be able to get them there. If there are concerns that people have in terms of privacy issues, like I said, have them talk to me. We are very, very good about protecting people's privacy, so they shouldn't have that concern. And we're trying to make it as easy as possible for people to do this. The first stage, and we're very mindful of this step, is to upload a copy of your genetic test report. And we're mindful that not everyone has a copy, so we actually make it easier for you. If you don't have a copy, you can sign a medical release. We'll do the work in terms of getting your genetic test report and be able to, find out from your doctor what that is. But we want to make sure that everyone we have within the registry really has Hive P2, right? It's very unusual. I'll reassure you of that. It is very unusual, but occasionally we've had someone who thinks they have one of these genetic conditions, and I'll review the report and I'll say, that's actually not the right diagnosis. You're in the wrong club. I'll sometimes help them to get to the right club. So in a good way, they get to a diagnosis, they get the right information, but we want to make sure for your sake that you're in the right club and you're getting good information. The problem is in terms of our numbers, we started out with 43 as an example, and you'll see from some of the numbers I'm talking about, we're down to about 30-ish or so people that the data I'm going to tell you about is based on. 30 is a good number, but it's a number that still feels like kind of a small number to some of the people who might be investing in this. And so that's part of why I keep sort of saying, we need to get our numbers up. We need to get our numbers up. As we're doing this, and as I said, we're not going to stop. So new people, new time points over time, we're going to keep doing this. And this is just to simply say, this is what we do in terms of making this information available to the researchers through those samples. And in particular, these are these iPS cells, iPSC cells that I talked about. For any researchers, this is mainly geared towards you. These are the lines that we currently have available, and so you can get them by going to Safari Base, and it's a minimal, just the cost of shipping to be able to get these cells. So it's a bargain. Within this, and I'm going to get back to the genetics in just a second, these are the particular genetic variants that we have represented. And I'm going to say a couple things about this. So I've separated these out into two groups. One group is over here on the right, and it's the majority as a big group. And then there's a smaller group here on the left. I don't expect you to be geneticists. That's not your, you don't have to do that, but I am going to show that in terms of these, anything that says pathogenic means that we're certain that this is the right diagnosis. We're certain that that particular genetic variant causes Hive P2. Likely pathogenic means we're almost certain, but we don't quite have enough information yet to be 100%, but we're pretty close. So I expect that with a little bit more time, a few more people that have the same genetic variant will be certain. What you don't see here, intentionally so, is that we have a few people who have so-called variants of uncertain significance. We call this VUS for short. Those are individuals who on their test report said, we see a genetic variant in Hive P2. We're not sure, though, whether it affects the function of that gene. So we're not sure that that's your diagnosis. We, like Misha in the back, actually spends a fair amount of her time watching these very carefully to see, do any of these change? Do they become likely pathogenic? In other words, a diagnosis or not? And so this will get updated over time, I'm quite certain. With this, all of these genetic variants over here on the right have the following effect. Each of us have 2 copies of our Hive P2 gene that we were born with. For everyone on the right, 1 copy of that gene basically didn't show up to work. And so instead of having 100% of the Hive P2 protein, you have 50% of the Hive P2 protein. This one went bye-bye. This one is trying to do all the work, and it's hard to do all the work when you're here by your lonesome. And so that's the primary problem. If we could, magically, we would make this guy work overtime, right? We'd double up and make them do twice as much work, and that would compensate for this one who hasn't shown up, right? That would be a magical solution for us. People are actually working on exactly that type of solution, just that those are some of the scientists back home working. These particular ones, these are very, very small changes within the gene. They may have very big effects, but they're very subtle changes. For these, this is one single amino acid or one single building block in the protein that is altered or switched. So that protein still shows up, still is present, still shows up to work, but it's a lazy guy, not really doing its job is what we think, although there's still some additional work to be done to just make sure that I'm right about that this is a case where, you know, although there might be 100% of the protein showing up for work, it's not working at 100% of the function that it should be. I bring this point up because this is my hypothesis. I think it's likely to be true, but if any of you notice that you have this particular type of genetic variant when you look at your test report, it is extremely important that you're represented in the research because as you can see, you're a relative minority compared to all of these that we think are acting in a similar way. So these folks, if you don't want to be left behind, really, really important that you show up and represent yourself so that we make sure we're covering your biology. Okay. Within this, this is just a pictorial mainly for the scientist to show where the genetic variations are. That's not nearly so important, but all of these slides, feel free to take a picture, but all these slides will also be available and the recording will be available. So if you don't see all of it, don't have a panic attack. This is just a fancy way of showing them in 3-dimensional space that we look at. And sometimes scientists look at this to see if we can understand better how that protein is functioning. And as we try and design drugs, whether or not there's a way to use that information. Okay, let me get down to the heart of what's important. And that's thinking about at the end of the day, sort of life and quality of life. Most of this is good news. And I want to celebrate the fact that over here on the right, let me start out by saying I will show you with all the slides. This is small numbers. This particular survey is only based on 5 folks. So just keep that in mind. It's small numbers. But when we think about feelings and emotions, and I can say just looking at your children here at this meeting, I become joyous in terms of seeing them smile and giggle and have a good time and running around like, whether it's with the reptiles or the magicians or in with the playroom, they are just joyful individuals. And I think that's ultimately part of my goal, is to make sure that we make those good days more than the bad days and continue that joy. With it, there are several activities that they like doing. Many of them, like being outdoors, like being able to play, like being able to move. But with this, predictability is also important, being able to know and expect. Otherwise, sometimes anxiety can be an issue. This is a little bit good news and bad news. I'm going to come back to this more, but in general, good health. Right. And so the one thing I want you to remember is that I'm not going to throw you any zingers, at least in terms of all of a sudden, from a health point of view. So far, we're not seeing like all of a sudden there's big cancer issues or big heart issues or big diabetes issues. That's not what we're seeing. And so in general, folks are in good health, and I'll go into deeper, more information about this. On the other hand, sleep is an issue. And again, this is just 5 individuals, but it's something I've heard from you as well. And I think in a good way, if we can help in terms of sleep, I think it's going to help with other things down the road. And you guys know this from personal experience. If you get a good night's sleep, you just feel better, you act better, you can learn better. In fact, the process of sleep helps with the consolidation of what we learned the prior day. And so sleep is really, really critical to a lot of things down the road. So if we can help with sleep, I'm convinced that we can help with a lot of other things. So you're going to hear us sort of coming back to sleep issues over and over again. But my concern is that sleep is not good for everyone. But on the other hand, like I said, that's the good news, bad news. It's not so good now, but maybe it's an opportunity for us to do things better in the future. When we think about this, also in terms of thinking of daily life, one of the things I want to emphasize over here, and I'm not surprised by this generation, is likes technology, right? And so is there an opportunity in a good way to use the fact that kids feel comfortable with the technology, to use technology as our friend? And so I'll plant the seed. Any of you guys in the audience or listening at home who are app developers or software developers or anything like that, I think there's a lot of power in terms of even just the power of what you've got in your phone to be able to help just in terms of daily life. And so opportunities, again, to be able to support our young people over time. In a good way, in terms of socialization, like doing things that are interacting with others to a large extent. We'll talk about it a little bit more as we talk about autism, though, some issues, right? Some challenges in terms of still being comfortable and being capable of interacting with others at the level that they want to. And so, again, something that we can still work on. Okay. So let me switch over to some medical issues. And so this is based on more individuals. This is now based on 19 individuals, just by chance, 13 males, 6 females, but now almost 20 individuals. So it's good that our numbers are a little bit more solid here. But I do want to point out one limitation. So here's the age distribution in years. So from birth all the way up to in the mid 40s. And this is the number of individuals who are in each of those age bins. And so the point that I want to make is we have only one adult who's represented within this, right? So that's in part because adults are not being diagnosed with genetic conditions like Hive P2. That's simply a matter of access to care and who's seeking a diagnosis and things like that. It's not because they're not out there. I fully know that there are adults out there, but they're not represented, at least in our registry. And to a large extent, it's because they're not being diagnosed. If there were something undoubtedly in your best interest, it would be to help find these adults out here, right? Because these are the folks that are going to help us think about what do we need to be on the lookout for in the future? What do we need to prepare for? Is there anything we can do to minimize future health risks? It's by looking at what's happened to some of our older folks here, right? So if there were one thing we could, or not just one thing, but one of the things we could do is to identify folks out here. The other limitation is when I think about the folks that we have here, most of our folks are pre-pubertal. So at least in terms of the data that I'm showing you here, most of them have not gone through all of the hormonal changes that happen with puberty. And there are things that happen just with normal kids when they're going through puberty, much less our folks. And so with this, it's still a limitation in terms of what I'm telling you, but obviously I want you to have all the data. So we're going to go through it. Okay. As we think about this, I'm going to show you these graphs in all the same way. So number one, this is again based on 19 individuals. And for each of these, of the 19 individuals, a certain number that have whatever this is shown on the left, and then in parentheses shows you the percentage of those individuals. It's not going to be at all surprising, and I know Charlotte was talking with you about this earlier, everyone essentially has something in terms of a neurodevelopmental condition, right? So depending on the age, it may be called intellectual disability, it may be called developmental delay, but it's not surprising. And this just, for me, says that, okay, well, you know, at least people, the right people that we surveyed in this is what I expected to see. On the other hand, there's some other issues that come up. And again, this may change over the life course, which is why we'll keep continuing to collect the data. But autism is not infrequent. Not everyone, though, has autism, but it is not infrequent. Attention issues, again, not as common, but we see attention and anxiety issues as well. And so again, this is something that we see commonly with other neurodevelopmental conditions. Most of things, just to give you a sense, are related to the brain and behavior. So again, just so you don't get worried, that's most of what I'm going to talk about. Within this, we do see fundamentally low muscle tone. So core, the trunk itself, but also legs and arms, low muscle tone. And that's why many of you, if not all of you, have been using physical therapy with your children, probably since they were itty bitty, right? And that helps to improve things. Doesn't make it go away, but it definitely helps. This low muscle tone, believe it or not, is not only seen in the muscles of the body here, but internally is also seen within some of those muscles as well. So I'm going to get to some of the gastrointestinal issues, but some of those are also related to essentially muscle tone problems also through the gastrointestinal tract. We see problems that are related in terms of movement or disorders or coordination disorders, which is being able to understand where your body is in space and coordinate that and be coordinated in terms of those movements. Also is related to the speech problems in the same way that you're talking about walking or being able to feed yourself and that coordination. It's the same thing that's going on in the mouth in terms of just think about what it's taking me to speak to you right now. Moving my lips, my tongue, my teeth, my throat. It's incredibly complicated when you think about it. It's like a miracle any of us is actually speaking in full sentences. And so in fact, that's one of the things we can tell our kiddos are understanding, right? They're listening, they're hearing, they're understanding much more than they can actually articulate or get out in terms of words from their mouth. So that's why we need to have means of expression if they're not verbal or minimally verbal, other ways for them to get their ideas out. And that's where I come back to the technology, right? Because, and you've been hearing about some of these things, technology can be our friend in terms of being able to help our kiddos express themselves better. There's some diagnoses that individuals get. Cerebral palsy is one of them. I think that's mostly that diagnosis. I'll have to tell you, I think is actually not a correct diagnosis, but I think they're getting that diagnosis because their muscle tone may be tight. They may be hypertonic in those cases. Physical therapy also helpful in terms of stretching out those tendons. And if that's a problem, really important to keep things loose. Otherwise, those tight tendons can cause problems orthopedically with hip problems that need surgery, mobility problems, other things down the road. And then some individuals have some movement, sort of repetitive movements that we call tics. And so that can be something else that we can see. Within this, in addition to those neurological conditions, the other medical problems, I'll just, even though those bars look big, I'll emphasize that when you look at the actual numbers, these are often onesies or small numbers. So again, don't want this as kind of an optical illusion. It looks like a scary big number. It's really not such a big number. But when you're looking at this, these are issues in terms of problems growing oftentimes this way or gaining weight in the small number of individuals. One of my fantasies that I hope we'll realize before long is to have a Hive P2 specific growth chart so that your pediatricians will know what to expect and not to get overly concerned if an individual is not exactly the 50th percentile in height. That's probably because Hive P2 as a group is not 50th percentile in height, and that's okay, right? And so I don't want anyone to have a panic attack over that. So we'll get there, but just word of sort of advance warning, we may come back to you to get some information about growth charts so that we can help to make those as part of future standards of care. Yes.
If you found your child from young was in the 10th percentile or the 30th or the 70th, did they, remain stable? Although they weren't 50th, did they remain stable as they were growing, or were they falling off the charts?
Yeah.
I don't know if you have data to talk through that.
Yeah, so it's a very good point. And unfortunately, the answer is we don't have the data yet. So although I said sort of my fantasy about doing this, what we've been doing is what we call cross-sectional data. So to be able to look at what kids are like at the time we talk to you. The longitudinal data is a way of putting the pieces together. But I think we're going to need to do at some point is get retrospective data. So in other words, come back to you and say, with the help of your pediatrician, be able to say, okay, this is what my child's growth was like from birth, and then be able to put that together for the whole group, separated by boys and girls, and be able to see what those expectations are. Not everyone follows exactly their growth chart. So I'll just say that's true for all children, right? Not everyone stays like they were born at the 50th and stay exactly at the 50th their whole life. Some people go a little up, some people go a little bit down, depending on when they have their growth spurts. But in general, what we're seeing is people tend to be below that 50th percentile. Now, they're not also teeny tiny. So I want to, if you're having issues with your child where they're like, skinny as a rail, that may be a problem. So I don't want you to totally sort of disregard anything I'm saying in terms of growth. What one guiding principle I will say is that weight should be appropriate for height, right? So there's a way that your pediatrician can look at the two of those together. And so if you're skinny Winnie, or if you're growing too much this way, that's also not a good thing, right? And so you also need to look not just at height or weight, but the two of those put together. Okay. So in terms of looking at other issues, one of the issues, and again, this is based on 19 folks, is that we do have a fair frequency of a variety of different visual issues or different eye condition issues. I bring this up because this is something that's treatable, very readily treatable. If you can recognize it, we can take care of it. Usually this can be taken care of, for instance, things like being farsighted or nearsighted or astigmatism in many cases can be taken care of with glasses, relatively easy. Sometimes it's hard to keep the glasses on. I appreciate that. And then in some cases, for instance, with a lazy eye, may need either patching or if patching doesn't work, surgery. I emphasize this though, because if you're not seeing clearly, you're not safe. You're not able to see the world around you. You're not able to see what's coming at you. I mean, as you can imagine, right? If you were going to wear a blindfold for your full life, life would be really hard, right? And that's essentially what we're doing is we want to make life as easy as we can for our kiddos and allow their senses, their vision and their hearing working as best that they can. So again, I say this because it's easy enough to do. I will say that, and I know depending on where you live, you may have certain providers that are down the street and certain providers you might have to go 3 or 4 hours to. This is the type of provider that it's worth making that 3 or 4 hour trip to in terms of making sure they get it right and they treat it right. So if you have to go to a children's hospital with a special ophthalmologist, pediatric eye doctor, especially one that takes care of children with special needs, neurodevelopmental needs, that's worth the trip in terms of getting that right. Within this, there are also a few other medical problems, and so I just want to highlight those here. We talked about vision, gastrointestinal problems, or a combination of diarrhea and constipation, and in some people both, and some people, even depending on the day, one versus the other. This is what I was talking about in terms of low muscle tone with the gastrointestinal tract. So that low muscle tone makes things go back up and you get reflux, and it also makes things migrate through the intestine very slowly. And with that very slow migration, that's what causes the constipation. I don't have a magic solution to this, although I'll say that there are multiple solutions. So that's the good news. Combination of diet, medication that helps with the reflux, and it's the same medication we use for all kiddos. It's nothing special in terms of that, or the constipation. Being active, physically active, keeps things moving along. And then consistency in terms of, and many of you are very consistent already in your schedules, but the consistency helps in terms of more regular bowel movements. So the usual things in terms of fiber, fruits and vegetables, all of those things help. Even prune juice, although it may sound like a cliche, those things help as well. And the reason I say this is because sometimes I think we don't realize how much things hurt inside, how many there might be cramps or problems that someone can't tell us about, and really sort of throw you off your game for that day. And so helping with this helps with a lot of other things. We talked about being on the shorter side. And then the good news to me is that in terms of epilepsy or seizures, this is not something that we're seeing very much in this community. And so within this, like I said, medically, really not a huge number of medical issues other than the ones I've mentioned. What I put up here for medications, the types of conditions that required medications. And the reason I put this up is because to me, it sort of passes a certain threshold if you need to use a medicine. You know what I mean? It's like someone thought it was serious enough that it needed permanent long-term treatment. And so with this, it's saying not just that it happened, but how significant that issue is. And so here are some of the things that we talked about. Issues in terms of neurobehavioral issues. Sleep, again, one of those issues that I talked about at the very beginning. Medications that help with epilepsy, and some of those medications also help in terms of other behavioral issues, problems with attention and focusing, and also other behavioral issues can be treated with antidepressants. So a lot of sort of things that are above the shoulders and requiring medications of one sort or another. And then, as I said, some GI issues, and then just, I think, some regular pediatric asthma or pulmonary or allergy conditions. Okay, we're in the home stretch here. So the last I'm going to do is tell you a little bit about something called the Child Behavior Checklist. Again, this was a survey that you guys did that reported in on behaviors that you were seeing. We divide this up into 2 age groups. So the younger age group is age 1.5 to 5. And again, there are 8 individuals represented here. Each of these colors represents a different group of behaviors: aggression, sadness, anxiety, attention issues, or oppositional behavior. And this is the group average. So this is the average for the entire group. There could be one child within this that was having an issue. But again, for the group average, this is what we're seeing. The good news for this group of young individuals is this is the area of significant concern. And again, you're seeing as a group. For the little ones, you're not seeing significant concerns in any of those areas. The attention issue is the one that grabs my attention the most. And again, you're getting right over here in terms of the borderline for the little ones. Now, moving up the age range, these are folks that are a little bit older. So these are 12 individuals now who are in the age group of 6 to 18. The same categories that we saw before. And again, these are group averages in terms of this. And again, significant concerns. You're not seeing on average significant concerns in the group, but you are starting to see, as we were seeing before, attention, definitely now in the mild concern area. And we're starting to see some things in terms of aggression and oppositional behavior, just at the borderline. Not a significant issue, but at the borderline. We've been carefully watching over time to see if things are changing over time. And puberty is one of the things that I'm most sensitive to, because a lot of kiddos, things change when those hormones change. And with that, I'm concerned just because I'm watching this carefully to see what's happening. And I will say, I don't think we have enough data. So far, nothing's popping up on the radar screen to say, like, danger, Will Robinson, there's going to be all hell to pay soon. But it is one thing we're watching closely, and we'll report back if we start seeing anything come up in that area. So just in summary, in terms of looking at some of the specific things that folks were reporting to us, we are seeing certain types of behavior, problems with attention, hyperactivity, problems in terms of, sensory issues, and having something that oftentimes either something you're giving them to be able to chew on a non-food item, or something that they themselves are doing themselves. And like I said, tending to be shifting pretty quickly, and early on some problems in terms of taking turns or being patient. With this sort of that same idea in terms of distractibility and hyperactivity, and now getting to some issues in terms of obsessions and sort of same things over and over again. And so just to give you a sense of how things might evolve over time. With this, I think hopefully by understanding what might be ahead, we're trying to help you both prepare and maybe guard against some of these issues, try and modify behaviors with some of your behaviorists to address these. So overall, like I said, the most common issues you already know about: focus in terms of the brain and behavior, focus on the eyes, and a few other things on the side here that we'll get more data over time to be able to inform, but not major health issues, right? So not major other medical issues, which is the good point. So focus in terms of your education, your behaviorist, and working on those areas. Okay, so I think that's all I've got here. And if I understand, we'll go to questions.
Okay, thank you so much, Dr. Chung. We have got almost 20 minutes to do Q&A. So Alisa and Charlotte are going to join Dr. Chung. I think Dr. Sid might be able to pop in as well. Erica, I feel like we should probably hit some of the virtual questions since we in the audience have been able to ask a lot and we haven't heard from them yet. Okay, perfect. All right, so Jennifer.
So this question's for Dr. Chung. So earlier in your presentation, you were talking about what our blood work is going to be used for, and you mentioned, testing different medications, et cetera. And so I'm just curious if there was any sort of like interesting finding with that, or if a specific medication found well to work well, like how do we get informed about that? Like, how does that get back to us?
I'll just use, I'm not sure what we're going to do, but I'll use this one. Okay, so I'm going to repeat the question to make sure I understood it. So when we're using things like induced pluripotential stem cells, or people are working on new treatments, how do you guys hear about this, right? So one of the things that we try and do is at the Simons Foundation to ask scientists for things like progress reports or being able to give updates to us. I will say that that often happens when it gets to the point of a publication. So once it's gone through what we call peer review, or other scientists being really rigorous to say, did you do that experiment correctly? Is it the right answer? But when it goes through that, then they'll tell us, yes, in fact, this is like top notch in terms of this, and send us a copy of the paper. And then we always keep this on our website, and we we distribute this in the union. Now, we have not been informed yet in terms of anyone who's gotten over the finish line for what you're talking about. So you haven't missed anything in terms of any of that, but it does take time. And oftentimes it takes years, unfortunately, in terms of doing that. But we're very committed in terms of both holding scientists' feet to the flames in terms of letting us know what's going on, and then relaying that information back to you. The one other thing I'll say that we're trying to do, although I have to admit it takes an army of staff writers to do this, is that if I were to hand you most of the scientific papers that these scientists publish, I don't know you well enough to know your background, but you'd probably come to me and say, what? Like, right. And so the problem sometimes becomes that the language they're writing, even for me, sometimes I'm like, I don't understand this. I need a translator. So we're trying to work really hard to do the translation into something that's digestible, and be able to say, what's the kind of take home message from this? What's the punchline? So if we don't hit the mark, you'll let us know, but that's what we're trying to do.
I have a question with you too. I can't remember your name, but about the blood work. My son's already did the blood work years ago. That's how he was diagnosed with Hive P2. Can they go back on his records and look at his records instead of giving blood again?
I want to make sure I got that right. So your son had blood work done years ago when he was diagnosed with Hive P2. And this is blood work done with your local doctor in your local hospital. And when you're talking about this, are you asking about the cells that we make from that? Or are you talking about things like, I don't know, how the liver's doing or how the kidney's doing or things like that?
No, I just wonder if they can use his blood results from years ago for that, but I guess they can't.
Yeah. So for the things that I talked about here, we can't just go back to records. We actually have to have living cells. And so what we've been doing here at the meeting is we take the cells and like we're lickety split processing these in a very special facility. They're being made. So if there was something like someone got a blood sample taken at a local hospital or doctor's office, even as little as last week, we can't use them for the things I'm talking about here. We have to do a very special blood draw here for that.
Is it too late in the day to get that done for my son today?
Is it too late to get that done? Tomorrow, we still have the folks here tomorrow. So see Jennifer at the end of the session. She'll show you where to go upstairs to sign up. But up on the third floor, we've got people that'll help you to sign up for that.
So I might just be a little slow on this, but I filled out all of the Simon's work like 5 years ago when my son was first diagnosed, and things have obviously changed. Everything that I probably answered back then, surveys and such. Is there a place to go back and redo or change some of those things on there?
The answer is yes. So if you go back in the hallway out here, we'll orient you in terms of at any point you can come back in. I know it's not obvious, but you can log back into the system and then pick up where you left off and be able to tell us how your son's doing now. But we'll help you log into the system and figure out how to do that. So just stop out in the lobby here.
On one of the slides, I think there's four genetic variants you had, and one said ARG 943, and then one said ARG 943 corrected. What does corrected mean?
You just say that one more
Oh.
time.
On one of the slides, I think you had some of the variants. I think there's 4 of them, and 2 of them were the same ARG 943, and then one said ARG 943 corrected. Just wondering what the corrected part
Okay,
means.
okay, I understand what you're saying now. So I don't know that I can go backwards to this, but anyway, when I had the slide about the induced pluripotential stem cells, there was one line where it said corrected on the right. You were paying attention. That's good. So one of the things that we do is we artificially, so some of you may have heard about gene editing, right? The idea that kind of like surgery, you could go in and snip out the problem and sew in the right version of the gene. Right now, we can actually do that type of gene editing in a dish. We can't yet do it in a person, but we can do it in a dish. For that particular cell line that I showed you, that's what we actually did. We took cells from that person that had that particular variant, and then we went in and snipped it out and corrected it. And that allows us to have kind of a really good control for researchers who are doing things, because then they can see if the cell has a problem, what happens, or if the cell has been fixed. Does it behave the same way or not? So that's something that we built into the system for researchers to have really robust data that they can generate.
Dr. Chung, I have a question too. So it looked like there was 13 males and 6 females currently in the study. Do you think that it's too early to know if it's impacting males more than females?
Yep, good question. So Nerissa is asking, in the data that I showed, it looked lopsided, right? It looked as twice as many males as females. This particular gene is on a chromosome that is not a sex chromosome. And so we ought to have equal numbers of males and females. That's sort of what the biology is. My suspicion is that's the way it'll turn out. Approximately, we may have what we call some ascertainment bias in terms of if for whatever reason, parents are more concerned about a male than a female for whatever reason, it might push harder for a diagnosis. But my suspicion is the biology is that it's equal numbers of males and females out there.
What are the genital and urinary tract issues that are coming up? I've seen some kind of things going on with my son, but
Okay.
I
I'm going to
didn't
ask
relate it until now, I guess, until I
Yeah.
seen that up
I'm
there.
going to make sure my data team in the background is feeding me the right answer because I don't want to mix it up. I think I know, but I'll give us 1 second. We're
Okay.
literally like looking in the background. Okay.
Wow.
So the problem, the problem that
That-
we see is in a male with the penis, that there may be the hole at the end of the penis, maybe a little bit lower, or the penis, rather than being completely straight, may be a little bit bent and curved. I don't think it causes any discomfort. I think
He's
I-
always digging at it.
I don't think it's from a functional point of view. Like, I don't think it's
Maybe he's
causing any
curious.
problems in terms of being able to urinate or more painful or anything like that. I think it's something that if there's a cosmetic concern, people might do a surgery to be able to fix that.
Just curious. Yeah.
I think that might be a different,
So I know you guys have mentioned like failure to thrive, not that often. I don't know if you have the answer for this, but did you notice anything that might have helped that? Because we noticed we're having that issue with our son. He refuses to eat. He's really not growing. He's in a very low percentile for weight. And doctors are like stumped. They don't really know what to do next for him.
So I'll answer this, Sid, if you have anything you want to add, feel free. But so as I was saying, there are 2 dimensions that I look at. There's the height and there's the weight portion of this. And so if it's simply a weight issue, like the height is okay, but it's simply a weight issue, then we tend to do things with dietary supplements in terms of, I'm not sure how old your child is, but either formulas that are higher density formulas or all sorts of foods that are bad for me at least, but might be better for your child, lots of fat and things like that. If it's an issue of height if the weight's okay, but it's a matter of height, it's more likely that that's just if you will, the instructions for the body are to be this tall, not to be this tall in terms of that. Now, there are certain people that would say, well, should we do things like try growth hormone, right? Growth hormone is the hormone that makes you grow. And so should we try that? The children I've seen are not growth hormone deficient. So it's not as if their body is not making the hormone to grow. It's just that they're programmed to grow in a different way. So if you try and override the system by giving more growth hormone, it's not likely that it's going to make a huge difference. Might make a little difference, but it's not likely that it's going to make a huge difference. And because it's an injectable medication and an expensive medication, most endocrinologists feel like, is it really worth it to do that if you get maybe a little something out of it? Probably not. So, but the best is to do, if you have any questions, either pediatric gastroenterologist and or endocrinologist, just to make sure there's nothing else going on, right? If there's a really severe problem, it's always possible there's something else going on that's treatable, and we don't want to miss that.
You could try asking for a referral for an occupational therapist who specializes in feeding therapy, who can also evaluate whether there might be a behavioral component. Is the child really sensitive to textures, and that's why they're averse to foods? And they can use some behavioral treatment methods to try to improve that.
Another possibility is, if there is an appetite issue, the individual doesn't feel hungry, there are certain medications that have appetite stimulating effects. So that could be potentially an option as well.
I have two questions about sleep. Dr. Sid, when you were talking about sleep, first question is there an age where naps are no longer appropriate, or taking naps, is that inhibiting any type of development?
Sure. Just to recap, the first question is, at what age are naps no longer or considered maybe less likely beneficial? I don't have a particular number in mind. I think it's one of those things. I think gradually, just over time, the napping that takes place during the day should get lower and lower to the point that there shouldn't be napping during the day if possible, and most of the sleep should be consolidated throughout the night. But I don't have a particular threshold or particular number. I don't know if Dr. Chung, you had thoughts about that either.
I feel like a neurologist told me in the past that we should stop napping at by 6 years old, and my son still needs naps often at
and
8.
that's why I think it's really individualized. I think some kids, there's a lot of activities going on and they really need it, and it's painful not to get by without a nap. So I think it's very individualized depending on everything that's going on.
Okay. And my other question about sleep is, can you talk to us about sleep studies, how you get referred to one, what you might find from a sleep study?
Sure. So the question is generally about sleep studies, how to get referred for one, what are the indications? First off, I'll just talk very generally about why would one consider a sleep study. So one reason to consider a sleep study, if there is concern for sleep apnea. Apnea refers to pauses in breathing, and this can be apparent by symptoms such as loud snoring. It can be also evident by actual apneas, which are pauses in breathing that can sound quite alarming during sleep. Other indications for getting a sleep study, sometimes some kids kick their legs all around a lot during sleep. So a sleep study can be informative to tracking how much to try to quantify these periodic movements, these movements affecting, the legs during the sleep. So in terms of referrals for a sleep study, so if there is sleep disturbance and you have suspicion for obstructive sleep apnea, meaning that there's snoring or actual apneas, or you really want to get a sense of, well, my child is moving their legs around a lot, I'm not sure what's going on, I'm worried about these movements in sleep, then those could be indications for getting a sleep study. Sleep studies pediatricians can refer for sleep study. If you see a neurologist or developmental specialist, they can also do a referral for a sleep study. It is, I will say that a logistical challenge that may come up with the sleep study is that it is kind of involved because you have to have different monitors placed. You have to have a a device that measures your oxygen levels, your heart rate. Sometimes they'll actually put little stickies, electrodes on your scalp and on your chest. You're connected to a lot of different wires. If your child has behavioral issues, sensory issues, that can be a challenge, and there may need to be a behavioral desensitization component involved. So that I think that's just one logistical thing to consider about a sleep study in this population.
Also about sleep, I like just the other day gave my kids some melatonin gummies, and I didn't research it before I did it. Is there any adverse, like, can you give it to them, and then if they just stop, is there going to be will there be adverse effects? Like, is it, you know,
Sure. The question is about melatonin and adverse effects of melatonin. So generally speaking, I think, you know, melatonin is a safe medication for children. I will say there's some recent data about just cautioning use of melatonin, and that relates to the fact that depending on where you get the melatonin from, there may not be as tight regulation about the how it's I guess the amount, and it's not maybe as tightly regulated as traditional medication. So just exercising that caveat about melatonin. But generally speaking, when we're talking about sleep medications, it is probably our most benign, so to speak, option. In terms of side effects, some families report, you know, vivid dreams with use of melatonin. There's no, and then sometimes families report that over time that the effect of the melatonin may wear off. It may not have the same kind of effect over time as when it was initially started. There is not, generally speaking, there's not a rebound side effects with discontinuation of melatonin. Some families use melatonin, you know, some nights, not consistently every night, and that seems to be okay, well tolerated, or not concerned for any rebound issues with use. Yeah.
Online question. So my daughter has always been a restless sleeper. She falls asleep okay, but is very restless and will spin around and jump around in a dozing sleep. What would you recommend to help the restlessness?
Sure. So the question is about a 5-year-old who has trouble with being a restless sleeper at nighttime, has trouble maintaining sleep at nighttime. So one thing that could be considered is, sometimes I'll check I'll do a blood test checking something called a ferritin level. If the ferritin level is low, and I hear the story about a child who's moving their legs around a lot in sleep and having a hard time sleeping, sometimes I'll consider an empiric trial with iron. So clinical scenarios, child who's having a hard time sleeping, moving their legs around a lot, is a restless sleeper. So doing a blood test called ferritin level. And if it's low, then considering a trial of iron for a couple of months, which sometimes alleviates those restless leg type symptoms. So that's a relatively kind of benign type of intervention that may positively impact sleep.
We are at the top of the hour, so want to give a huge round of applause to our panelists. Want to thank the Simons Foundation tremendously for everything. I want to thank you parents for making the effort to come here. Again, I'm a parent. I know this is not easy. A lot of sacrifices to get here. It's meaningful. It's worth it. So thank you. A few housekeeping things. So we are going to have our Hive P2 group photo at 4:30 out by the Simon Searchlight banner. So that's here in 30 minutes. You guys can take a break, but make sure you're down there promptly.